Good morning. My name is Steve Denning. I'm the chairman of the conference committee, and we're happy to be able to bring this conference to you. Would have preferred to do it in person, but we do thank you that you have joined us. I hope you were able to attend the first Saturday last week. We had a great turnout, and we had great presentations, and we have even better presentations this week, I believe. And I am your host. I will be running the controls, but behind the scenes, and I am going to turn this over to Gene Brooks, who will be your host. And Gene, are you there? He will be your moderator. Let him get his camera turned on.
I'm here.
There he is. All right. And I am going to turn it over to Gene as our moderator. And Gene, take it away.
Okay. So welcome everybody and happy Saturday. On behalf of the Prostate Cancer Support of New Mexico, I welcome you. Welcome you and thank you for spending your Saturday with us. As Steve mentioned, my name is Gene Brooks. I'm the moderator. I'm a member of Prostate Cancer Support of New Mexico. And now, on to the conference. Welcome to the second part of our 9th annual conference for the Prostate Cancer Support Association of New Mexico. We hope you get a real benefit or got a real benefit from the first day. If you are signing in for the first time, let me welcome you and let you know that this was a 2-day conference and a recording was made of the first day and will be available on our website following the presentation. The Prostate Cancer Support Association of New Mexico is in its 29th year, and our mission is to provide current information, education, and support to men and their families about prostate cancer diagnosis, treatment, and living with the disease that affects 1 in 9 men, and at some time in their lifetime. Prostate cancer is the most common cancer among men after skin cancer and is second to lung cancer in the number of deaths related to it. But prostate cancer has some unique qualities which make education about the disease so important. Our group is an all-volunteer organization of men and women who have firsthand knowledge of the disease and who desire to share that knowledge and experience so that others may have the benefit of that knowledge when we make those life-important decisions. Prostate Cancer Support of New Mexico maintains an office, a website, and someone is always available by phone 24/7. We also host bi-monthly support meetings, frequently with guest speakers, and we maintain a library of valuable books and DVDs. When you think about it, that's pretty amazing for a volunteer organization that helps over 150 men and their families a year. Even though we are a volunteer organization, we are an organization nonetheless with real expenses. We try and keep expenses to a minimum and rely on small contracts and donations for our income. We don't charge for our services, and that's why if you receive a benefit from our services, and especially this webinar, we ask that you consider making a donation to Prostate Cancer Support of New Mexico. It is fully tax deductible. Donations can be made in a number of ways, but the easiest is to visit our website at PCSANM.org and click on the donate button. Since Prostate Cancer Support of New Mexico is run by volunteers, we are always seeking more volunteers to fill many of the needs of the organization. Some of those needs include one-on-one support, hosting and organizing support meetings, maintaining the website and Facebook presence, promoting advertising, maintaining the library, attending health fairs when they become safe again, and just be willing to share your experience through our buddy lists. If you have a skill that could benefit the organization or the people we serve, contact us. Our phone number, website, and address, and email address will be displayed periodically throughout the conference. Now, more about the conference. We are offering this conference to provide up-to-date information about the diagnosis and treatment of prostate cancer and to introduce you to some of the excellent resources we have available in New Mexico. We have broken the conference into 2 days because we know how difficult it would be to sit through a full day presentation on a small screen. Here is today's schedule. We have Dr. Gesualdo is first up, and he will be presenting at 9:10 on information about active surveillance. And we have Dr. Schroeder, who will cover the full gamut of localized treatments. And finally, at 10:45, we have Dr. McEnany, who will give us a concerning picture on the state of rural healthcare in New Mexico and beyond. Following the presentations, we will host a question and answer session with all three doctors so they can answer your questions that you raise during the presentation. We are bringing the conference to you via Zoom webinar, and there are some distinct differences from Zoom meetings. First, you will note that your personal video is not shown on the screen. That means you will not be able to verbally and visually interact with me, the presenters, and the hosts. In Zoom webinar, it is assumed that we are presenting information to a broad audience and interruptions are not allowed. That being said, you can ask questions via Q&A button found at the bottom of your screen. By clicking on it, you can type your questions in at any time, and the hosts will be able to direct the question to the appropriate person. This will be especially true during the question and answer session at the end of all presentations. Your response will let us know and be providing a service to you, and we ask that you give us some good feedback to let us know about future conferences. At the end of this conference, we will provide a poll to ask you how we did. And when you see the questionnaire appear, please take a few minutes to complete it. Our first presentation is by Dr. Aaron Gesualdo. Dr. Gesualdo is a urology surgeon currently employed by the Loveless Urology Group. He has spoken at our conference in the past, and we are happy to have him. Remember, you can ask questions during the presentation by clicking on the Q&A button at the bottom of the screen, and they will be answered during the Q&A session following all three presentations. With that, here's Dr. Gesualdo.
Hello everyone, happy Saturday. My name is Dr. Aaron Gesualdo. I am a urological surgeon employed by the Loveless Medical Group. I work out of the Loveless healthcare system. I've been in practice since 2005 here in New Mexico. I've been working with the Loveless Medical Group for the past 2 years, and prior to that, working with Presbyterian Medical Group. I run a very diversified practice that deals with all different types of urological oncology, including prostate cancer, bladder cancer, kidney cancer, testicular cancer. Also dealing with BPH or benign prostatic hypertrophy with lower urinary tract symptoms, kidney stones, and incontinence. Me and my well-qualified partners, Dr. Andrew Grohlman and Dr. Tomi Perez, are accepting new patients. Today's lecture is about prostate cancer and active surveillance. I will be discussing how active surveillance works and how it applies to the low-grade and very low-grade diseases. I'll also give some insight into the treatment options that are available for the very low and very low-grade diseases and touch on some of the other treatment options available for the higher-grade diseases. So before we talk about active surveillance, we should talk about detection and detecting a disease in its early stages when it may be asymptomatic and not show any symptoms. The first thing I'd like to talk about in detection is a screening tool we call the PSA test. The PSA test is a blood test. And the PSA, as defined by the Prostate Cancer Foundation, is a protein that is produced only in the prostate. Both healthy and cancerous cells make PSA. When a disease state such as prostate cancer occurs, PSA is leaked out of the prostate cancer cells and it is absorbed and floats around in your bloodstream. By detecting higher levels could indicate that you have prostate cancer. And we may have heard some things about the PSA test that is not that accurate, and it is true. Other things can cause the PSA to be higher and lead to unnecessary biopsies, worry, morbidity, and that's why there's some controversy surrounding the PSA test. So why is the PSA test controversial in screening? The National Cancer Institute describes the PSA controversy as follows. Using the PSA test to screen men in prostate cancer is controversial because it is not yet known for certain whether these tests save lives. So I get a lot of questions from patients when you should start screening for the PSA test. It's also a big question amongst general practitioners. So currently, for men under 40, there's no indication for screening of their PSA unless very special conditions exist. A strong family history may be one, injury to the prostate, some other abnormality that can't be explained and testing could be done in men under 40, but has really not shown to have any general benefit to start on the healthy male below 40. Now, for those men between 40 and 54, it is currently not a routine test that should be ordered. And unless that patient has some specialized kind of condition, that a PSA test should not be ordered. And one of those things could be strong family history again. Now, for those men between the ages of 55 and 69, PSA screening has been shown to have the greatest benefit. For men above 70, a couple of things have to be taken into account: lifespan, comorbidities, family history. So currently, you can tailor the PSA screening test to the individual. And the most benefit is from those men between the ages of 55 and 69. Now, a PSA test is also useful when taken also with a digital rectal examination, a complete GU history. So what's the difference between early detection and screening? Really not much. If you think about it, this is the pre-symptomatic phase where that person would have no other reason to be in the doctor's office based on his symptoms. So the PSA test is usually elevated and then results in a prostate biopsy. So some of the PSA derivatives that are out there, let's say the free PSA or the urinary biomarkers, the doubling time, there's limited evidence that this helps in the detection of prostate cancer. So there's not one great test that's out there. So the group that gets the best benefit by screening with the PSA test is that age group between the ages of 55 and 69. Now, the biopsy diagnoses the prostate cancer, and that patient has prostate cancer. We classify prostate cancer based on a couple of different factors, but the one that is most common is the Gleason score. And we can rate that at a very low risk, intermediate risk, and high risk. So each one of those classifications or grade, you have specialized treatment options such as active surveillance, surgery, radiation, cryotherapy, high intensity focused ultrasound, and focal therapy. So after you're diagnosed with prostate cancer, counseling should begin with your urologist. And any decision and discussion should be centered around a shared decision-making process. During that conversation, you have to consider risks, life expectancy, pre-treatment conditions, your lower urinary tract symptoms, and then the post-treatment functional status. You need to talk about related high-risk behaviors such as tobacco use, obesity, and you have to encourage patients to seek different prostate cancer specialists. Radiation oncology has to be part of that discussion. Oncologists, family doctors, and other support groups should also be brought into the discussion. And occasionally, we also talk about clinical trials that may be available in that area. So what criteria is used to place a patient into different classifications? The three main components of placing a patient into a classification is the PSA, the digital rectal exam findings, and the Gleason score. In general, those patients who are very low risk or low risk have a Gleason score of a 3+3 or lower, a PSA less than 10, and a negative physical exam finding. During this time, once that patient is placed into a very low risk or a low risk classification, a CT scan is not part of the asymptomatic prostate cancer diagnosis. It is not recommended to perform an imaging study for follow-up regarding the level of their PSA. Active surveillance should be recommended for those that are classified at a very low risk. Now this brings up the question, what is the difference between a very low risk and a low risk disease? Usually both of them have a Gleason score of a 3+3 or less. The difference between a very low risk and a low risk comes down to the volume that's detected. Now some that are classified as a low-risk disease may have a higher probability of progression. Maybe those that are diagnosed at a young age, or those with a very strong family history. In these patients, you can consider a treatment option such as surgery or radiation. In the low-risk disease classification, cryosurgical ablation of the prostate has not been shown to surgically benefit that person when compared to active surveillance. There's a lot of discussion about high-intensity ultrasound focal energy. And this is not a standard of care in America. In those that are diagnosed with a low-risk disease and have less than 5 years of lifespan estimated to be left, watchful waiting is recommended. Now, there are some biomarkers that are available, and there's been talk about using these with the low-risk disease classification. Biomarkers have not been shown as a clear role in the selection of candidates for active surveillance. Intermediate risk. Intermediate risk of after the diagnosis of prostate cancer in general are those that are classified with a 3+4 or a 4+3 disease. Staging should be considered in this risk group. You have to look at favorable and unfavorable medical conditions, risk associated with treatment, and either a CT scan or an MRI is recommended. Now, treatment options for the intermediate risk does include active surveillance in certain circumstances, surgery, radiation, hormonal treatments, and also some of the other options such as cryosurgical ablation or high intensity focal ultrasound. Active surveillance in this classification does carry a higher risk of developing metastatic disease the longer that person lives compared to more definitive treatments such as radiation and surgery. Observation for these types of people that have less than 5 years left of life, or an estimated 5 years left to live, is recommended. Now, for the high-risk disease, an active treatment is usually recommended unless they have a very limited lifespan or high degree or high probability of comorbidities. So now that patient has been diagnosed with prostate cancer, there are certain guidelines to follow when choosing to undergo active surveillance. First, rule number one, or guideline number one, is that the prostate cancer was diagnosed by a transrectal ultrasound guided biopsy of the prostate or an MRI guided biopsy of the prostate. Number two, that the PSA and the digital rectal examination have been done and continue during their active surveillance time period. There are different intervals that the PSA will be monitored, but in general, every 3 to 6 months, a PSA is drawn and reviewed. And a digital rectal examination should occur during those times. Guideline number 3 states that basically a confirmatory biopsy within the initial 2 years of the diagnosis of prostate cancer should be done. Now, what that is supposed to mean is to double check on the classification that you received. A patient is diagnosed with prostate cancer, is put into a low risk group, and a confirmatory biopsy is done within 2 years to make sure that that classification is correct. So that patient who is undergoing active surveillance is interacting with their urologist quite frequently. PSA, digital rectal examinations are being done. And I also recommend that biopsies be done periodically. And usually every 1 to 2 years, a biopsy should be done after the initial confirmatory biopsy completed after the initial diagnosis. This is to monitor the disease and that it doesn't progress. Now, one of the other ways of also monitoring this is with a multi-parametric prostate MRI. This MRI can show progression within the prostate or subtle changes that wouldn't otherwise be felt or maybe even biopsied. And if a change was noted, maybe directed biopsies can be placed into that area, either under MRI guidance or even in a general field. So just straight imaging of the prostate using an MRI can be helpful in the active surveillance. Now, some of the tissue-based genomic biomarkers, there is no clear role for active surveillance. They may provide additional information, but are generally not recommended. The offer of definitive treatment to localized prostate cancer is offered to those patients who actually advance while they're undergoing active surveillance. So to summarize, active surveillance is watching your prostate cancer. Those with very low risk and low risk classifications can be safely monitored unless changes occur that warrant further investigation or treatment. Those with intermediate risk and high risk disease are more actively involved with treatment plans, but active surveillance may serve some of those patients with certain considerations. When you're undergoing active surveillance, monitoring with the PSA and digital rectal examination is done regularly, usually a few times a year. MRI images of the prostate also aid in following along with active surveillance. Undergoing active surveillance that shows progression should move on to a more definitive treatment. Active surveillance in certain classifications, and especially in intermediate type of cancers, may result in metastatic disease. We have a lot of patients these days undergoing active surveillance. For the most part, these patients are doing well and have made good choices. It is a conversation that you have with your urologist, and understand that the technology in the future may change that may make active surveillance more prevalent, but definitive treatment is always an option.
Thank you, Dr. Gesualdo. That was an awesome video, and I'm looking forward to the question and answer period. Our next presenter is Dr. Tom Schroeder. And Dr. Schroeder received his bachelor's degree in physics from Colorado College, and then went on to receive a master's degree from Stanford in aeronautical aerospace engineering before returning to the University of New Mexico to earn a doctorate of medicine degree. He interned at UNM for 2 years, then attended Baylor College of Medicine for a radiation oncology residence. He returned to New Mexico to be an associate professor and medical director at the UNM Cancer Center since 2007, and has maintained those positions for over 13 years now. Dr. Schroeder has been a favorite presenter and moderator at the Prostate Cancer Support Association's previous conference, and we're happy to have him back. Even though Dr. Schroeder is a radiation oncology expert, we've asked him to give an overview of all local treatment options. And now, here's Dr. Schroeder.
Good morning. My name is Tom Schrader. I'm from the UNM Cancer Center, and today I'm going to be talking about localized treatments for prostate cancer. As all good presenters do, I'm going to tell you what I'm going to tell you. I'm going to tell you what to tell you, and then I'm going to tell you what I told you in an effort to make this stick. Hopefully that'll be helpful for you. So the first thing I'm going to do is I'm going to do just an overview of all localized treatments for prostate cancer. In that, I will give some indications for when they're used and a little bit about results from those types of localized treatments. When I'm done with that, that's going to be the bulk of it. When I'm done with that, we'll talk about some interesting, important recent developments in prostate cancer. And there's several of those, including the findings of a randomized study that's actually now 4 years old, looking at active surveillance versus radiation versus surgery And then I'm going to talk a little bit about something called the Space OAR device, imaging for cancer after you've undergone treatment, and also the role of localized therapy in treatment of prostate cancer when you have metastatic disease. And then I will answer any questions. Okay, first, all localized treatments. A quick overview of some, I'll just give one slide on some history. I'll talk about surgery, then I'll talk about radiation therapy. There'll be a little bit more there. Sorry, I'm a radiation oncologist. I'll talk about cryotherapy, high-intensity focused ultrasound, as well as laser ablation. Okay, history. I think it's safe to say, as far as localized treatments for prostate cancer, it all began with a guy by the name of Hugh Hampton Young. This was a famous surgeon from the Johns Hopkins Medical School, and I think was one of the founders of the Johns Hopkins Medical School. And he was the first really to perform prostatectomies, as well as the first to do radiation therapy for prostate cancer. Others may claim that they were the first to treat prostate cancer with radiation, but he's the first to actually do studies and write about them. He performed the first radical perineal prostatectomy. This is actually an approach that's no longer commonly used, where you come in from the bottom as opposed to coming in from the top, and he reported on results for that. He was also the first to perform what you would call primitive brachytherapy. He used radium needles either through the rectum or through the urethra to treat prostate cancer. Not very nice ways to do radiation, but back in the day, I think that's all they had. You can actually find his studies if you look on Google Scholar. They're from 1905 and from 1917. And both of those will give you an idea of how they did surgery and radiation over 100 years ago. I will warn you, however, these studies are very difficult to read. They're very wordy. But he is the grandfather of urology and probably the most important historical figure as far as localized treatments for prostate cancer. Okay, let's talk about surgery next. Surgery is still one of the gold standards for the treatment of prostate cancer. Many would say it is the gold standard for prostate cancer. The most common treatment performed today is the radical retropubic prostatectomy. It's getting about even out there, whether it's done open or whether it's done with laparoscopic robot-assisted prostatectomy. That's where they actually use the Da Vinci robot to do the surgery actually within the abdominal cavity. So in this case, small ports are placed which get them through the skin, and they insert their instruments through those ports, inflate the abdomen with carbon dioxide so they can see, and then do the procedure. There's a bit of a debate about whether the Da Vinci laparoscopic approach is better than the open prostatectomy. I will give you results of a randomized study that was performed. I think you will find plenty that complain about the randomized study, saying, you know, it didn't appropriately address things, or it was done too early before robotic techniques have gotten good. I think in the end, what you will find with the prostatectomy is the most important part of the prostatectomy is doing whatever the surgeon is comfortable doing. If you talk to urologists, the ones that do the open prostatectomy say they're more comfortable doing that. And I think one of the principal reasons that they're more comfortable is that they're able to feel with their fingers, which you are not really able to do with the robotic device. And so they say feeling is more important. The guys that do the radical prostatectomy via the Da Vinci device laparoscopically, they think seeing is more important because they get a magnified view and they can get in there and see a lot better. They're better able to do the procedure. I think one difference among them is in the case of the laparoscopic procedure, the healing time may be a little bit less because you do not have to deal with a large abdominal scar, which can take some time to heal up and may limit some of the things that you do. But it is important to remember that all the surgery that's done on the inside is pretty much the same. They're removing the entire prostate. And when they remove the entire prostate, they have to sew the urethra back together. And it takes time for all of that to heal. So although the healing times may be a little bit faster with the laparoscopic approach, you still have to heal the internal parts very well. With a surgery, one of the big benefits of surgery is that it's a single event. You go in, you get the surgery. It's somewhere in between 3 and 6 hours, and you recover from the surgery. You spend perhaps 2-3 days in the hospital, maybe more, depending upon how well the surgery went and whether there were any complications. Typically, this is a common procedure, so there's not a lot of complications, but it is a relatively big surgical procedure, and so there is some issues with recovery. After you're discharged with the hospital, typically you have to have a catheter in place. That's necessary in order to give time for the urethra to heal around the catheter, so you have a nice open pipe to urinate through, and that takes some time as well. As far as the complications from a prostatectomy, in the hands of a good surgeon, the complications from prostatectomy are relatively small. The biggest one that's worried about is urinary incontinence. This is where you can leak urine from the bladder, and you lose control of holding the urine in. Depending upon how that's defined, these rates can be very low, less than 5%, or upwards of 25 to 33%. It's not unusual for a man to have to wear a pad afterwards, but in the hands of a good surgeon, that's probably less than 10% of the time, and with properly selected patients. As you can imagine, the older you get, the harder it is to tolerate a big surgical procedure. So commonly surgeons like to select men that are younger with earlier risk prostate cancer. But the procedure can be done on men with more advanced prostate cancer, however the risks are higher. One of the very big advantages of surgery is we get to analyze your prostate after we've removed it. And this can tell us quite a bit more about your prostate cancer and can lead to recommendation for more treatments after your prostatectomy if necessary. These can include radiation therapy with or without hormone therapy in a large amount of patients that have more advanced disease. As far as usually the biggest question with all of these localized treatments has to do with erectile function. And studying erectile function can be very difficult because depending upon how you ask the question, you're likely to get differences in the answer more than you would by how the prostate cancer is treated. In other words, there's so much error in the obtaining data from with regards to erectile function that it's hard to compare and contrast among different modalities. Having said that, if surgery can be performed and you can do a bilateral nerve sparing procedure, this is where they spare the nerves that come from that are important in erectile dysfunction that run along the back sides of the prostate. If they can spare both of those, you can get some of the most durable and best results with regard to erectile function. One thing surgery rarely, if ever, causes problems with is the rectum. We'll talk a little bit more about that because radiation can cause damage to the rectum. On the right side of the screen, you'll see the results of the randomized study that I discussed between radical retropubic prostatectomy of an open nature and the robot-assisted laparoscopic one. And if you look at the numbers there, you'll see really they're looking at both incontinence and erectile function. And if you look at the numbers, they're very, very similar. There's very few differences between the numbers all the way down, which I think is good evidence that it doesn't really matter which way you get a prostatectomy, your results are going to be pretty similar. There are plenty of urologists that would probably disagree with that statement, but that is what the data shows. I did add in one other quick example of results. One of the big reasons that people are promoting prostatectomy in the modern era now is in patients with higher risk disease. So patients who either have a lot of prostate cancer in the prostate or have higher Gleason score prostate cancer may benefit from a combination of surgery with radiation that follows, as opposed to the more traditional route of giving radiation with long-term hormonal therapy. This has never been put to a randomized study, which is the best way to find this out, where we take a whole bunch of men that have equivalent indications and we either treat them with prostatectomy and radiation, or we treat them with radiation and hormone therapy and look at the results. That, to my knowledge, has not been performed. However, this comparative study does have suggestions that in overall survival, you may do a little bit better with surgery and radiation to follow than with radiation and hormone therapy alone. I'm not sure that I believe that, but it is a debatable finding from these comparison studies. Okay, moving on. Next, we're going to talk about radiation for prostate cancer. So radiation is probably the next most common, or maybe the most common form of treatment for localized prostate cancer. And there are a variety of different ways of giving radiation treatment. And what I've displayed on the screen here are different ways in which radiation can be performed. The most common of these is external beam radiation therapy. That you can see kind of a picture of in the upper left-hand corner there. That's where you come into the radiation center, you lay down on the table, usually with a mold, which is not displayed on this picture, and we line up to your prostate and give you a radiation treatment with external beams. If we're using traditional x-rays for this, which is the most common form, the treatments themselves are rather short. You're probably in the room once we get you started and going for about 10 or 15 minutes, and door to door it's probably about 30 minutes. One of the big problems with this treatment approach is that it requires multiple treatments. So you don't just get one treatment and you're done. The typical thing is to give daily treatments for a large number of treatments. Conventionally, the old standard for this would be to give in the neighborhood of the high 30s to low 40s, which if you do the math, getting treatments once a day, 5 days a week, that ends up being, 8 or 9 weeks worth of radiation therapy, or approximately 2 months. This has been one of the biggest detractors of the external beam radiation therapy. In general, it's pretty well tolerated, and I'll talk about sort of the complications associated with it as we get further along. One of the new developments in this form of radiation treatment is we're starting to shorten the treatments. These days, most centers will not be doing those high 30s to high 40s numbers of treatments, and instead we've dropped it to sort of the high 20s. So we have been able to cut off a few weeks of the radiation treatment, and we have not noticed differences with that. There have been several randomized studies that have proven that whether we do it over a long period of time or this relative shorter period of time, that the outcomes are essentially the same. Having said that, there may be some circumstances if you have a lot of urinary problems or an enlarged prostate where your provider may decide that they want to go back to the more conventional form, as some of the toxicities in the short term may be a little different. But for the most part, people believe these treatments to be equivalent, and so as a result, everybody is moving towards the shorter treatment. This is referred to as hypofractionation. If you're looking in the literature, you'll see a lot of studies with regard to that. One of the next most common ways in which we give radiation to the prostate, and this can be done in conjunction with external beam radiation therapy, is to do what's called a seed implant. In that case, what we're doing is we're actually inserting small capsules, and these are titanium capsules that contain radioactive materials on the inside of these. These are placed throughout the prostate, typically under ultrasound guidance. Some institutions have toyed with doing it under magnetic resonance imaging guidance, but for the most part it's done under ultrasound guidance. And those little capsules stay in your prostate forever. The radioactive material, however, decays and gives off its radiation, so after a period of time, the little titanium capsules are essentially inert. There are different radioactive materials that are used to do this, and this has the benefit of, again, being a discrete event. Typically, this is an outpatient procedure that doesn't take very long. You'll probably be in the operating room for 2 or 3 hours, sometimes less, depending upon what technique they use. And usually it's probably takes all day to get through everything, with the pre-op stuff and whatnot. But it is an outpatient procedure. You get it and you go home. There is not a lot of healing associated with this. For the most part, we're only using small needles that are placed through the skin in between the anus and the scrotum, what's called the perineum. And so as a result, there's typically not a lot of bleeding or complications with regard to surgery. And so you recover very quickly. Once you've recovered from the anesthesia, you're pretty much back to normal. And in fact, the side effects from this only ramp up once the radiation dose ramps up, which takes somewhere in between 3 to 6 weeks before it ramps up. This can be a great procedure, especially if you have a low-risk prostate cancer, because you're in and out again. These days, I think you're going to find that it's used a little less than it used to be used, and one of the reasons for this is with the external beam radiation treatment, we've actually started doing treatments where we only treat you with 5 external beam treatments. This is referred to as stereotactic body radiation therapy and demonstrates excellent results, and it's now recognized as a standard of care approach in patients with early either low risk or early intermediate risk prostate cancer. It also seems to be being extrapolated into the higher risk patients, but long-term studies have not yet proven those to be equivalent. Again, it seems to have similar side effects long-term when compared to other treatments with radiation for prostate cancer. Going further to the right there in the upper right-hand corner, you will see depictions of a different type of brachytherapy. Brachytherapy is where we're inserting radioactive materials into or next to the cancer. That's the stuff that Hugh Hampton Young did back over 100 years ago, but has now been optimized. In this case, instead of dropping seeds into the prostate to give off the radiation, we can put catheters into the prostate and then give you a discrete treatment where we put a very high dose rate radioactive material inside those catheters, again treating you from the inside out, and the results are very similar to the brachytherapy done with seeds. This is done as a sole treatment for prostate cancer, as well as treatments in conjunction with external beam. Some of those treatments in conjunction with external beam, particularly for high-risk patients, have shown excellent results. There are results from randomized studies in higher-risk patients comparing this approach to external beam radiation patients, and there is a suggestion that the results may be a little bit better at controlling the prostate cancer. Most radiation oncologists recognize this as the ability to give a higher dose with the brachytherapy, which may help to control the prostate cancer better and decrease the likelihood of the cancer coming back in the gland. These improvements are very small and sometimes have been associated with increased toxicity to the rectum, so we got to be careful here in applying these to most patients. Now, across the bottom of the screen, you'll basically see some images that show how these different treatments work. On the left, you'll see those are external beam radiation treatments showing deposition of the radiation dose into the prostate, and you can see how it curves around the rectum, which is at the bottom part of the screen outlined in orange, and you can see the prostate just above it on the image, just in front of it anatomically, and you can see where the red, which is the high dose of the radiation, is really going into the prostate, with very little of it going into the rectum. Just to the right of that, you'll see sort of what happens after a seed implant. You can see all of those little tiny titanium capsules within the prostate. And to the right of that, you can see the catheter-based approach of high-dose rate brachytherapy, where you can see all the catheters on a CT image within the prostate. These are some of the ways in which we can give radiation, and these represent the most common ways of getting radiation treatments. What are the benefits of this approach? Again, non-invasive. particularly with regard to the external beam radiation therapy, it's very reproducible. What does that mean? Well, that means if you get treatment at a small center in a suburb or here in Albuquerque, your treatments are not really going to be any different from the treatments that you would get at some huge major center like MD Anderson or Memorial Sloan Kettering. It's very effective. It controls the prostate cancer, and it also has very low toxicity rates. The treatments themselves are quick, and they're without any pain or discomfort, and can be done throughout the United States. The big detractors, particularly with the external beam radiation therapy, is there's just too many treatments. It's inconvenient. It's also expensive. Radiation therapy machines are expensive. You have to pay for all the support staff, including physicists, dosimetrists, radiation oncologists, therapists, those kinds of things. So it can be one of the more expensive treatments. Comparing it to the prostatectomy, you'd be surprised. All the hospitalization and that stuff adds up in cost, and many of those types of financial comparisons have shown that there's not huge differences with regard to cost. And so this also represents a very good treatment. Surgery and radiation, the first two slides that I've gone over, are the most common forms of radiation and are really the standard of care treatments available for prostate cancer. We'll now move into the treatments that are a little, well, either a little less standard of care or non-standard of care, depending upon your point of view. Once again, the future here is to reduce the number of treatments. We're going to be able to do that pretty readily. Right now at UNM, we're doing the 5-treatment thing for early prostate cancer quite commonly, and in fact are participating in a large national randomized study where we're comparing 28 treatments with 5 treatments. Okay, the next thing I'm going to talk about is proton therapy. Many of you, especially if you're looking at the internet, will see people advocating for proton therapy, see commercials about proton therapy. Actually, many members of the Prostate Cancer Support Association of New Mexico are former members who have gotten prostate cancer treatment with proton therapy out at Loma Linda and had excellent results, and are proponents of that treatment. But I think it's important for me to sort of go over what the purported benefits of proton therapy are, and why they may not be as beneficial for prostate cancer. So the big thing about proton therapy is it deals with what's called the Bragg peak. And I've tried to demonstrate this on this screen right here. If you look to the right, you'll see an image with sort of the tan oval. The tan oval is supposed to be a person. The red beam is supposed to be a beam of radiation. And the little gray oval at the top is the device emitting the radiation. If you do that kind of a treatment approach where you use a single beam administered to a patient or to tissue, what you will see is the sort of dose depth curve on the left. Now, what is a dose depth curve? Well, if you look, the y-axis there going from 0 to 100% is the amount of energy deposited by that beam as a function of depth in the tissues, which is the x-axis as you go along the bottom. Now, the photon beam, in this case, they're using a 6 million volt X-ray. That's what that 6MV stands for. You can see it spares a little bit of skin as it goes in, but when you get to a depth that's around 1.5 to 2 centimeters, that's where the majority of the radiation is deposited, and then it deposits less and less as it goes deeper and deeper into the tissues. If you look at the bottom red beam, the native proton beam, and with this, in this case, is a 250 million electron volt beam, you will see that on its way in, it does not deposit very much tissue, about 25 or 30% of radiation to the tissues that are in between 0 and about 25 cc's in depth. And then at the end deposits all of its depth into the tissues. And then there's virtually none that exits. This gives it the real advantage. In other words, when we're using a single beam, we can really point that beam by changing the energy of the protons and get it to go to the depth that we want it to go, with very little coming in and virtually none exiting. This means we're putting the radiation more where we want to as a function of depth. Now, when you want to treat something that's got a little bit of depth to it, then you have to modify that proton beam in order to get that radiation to those differences in depths, and that's what you get with that modified proton beam that you see in blue. This is a physical advantage that is true and real. Now, the real question is, how does this help with the radiation treatments? Now, in general, radiation oncologists, if they can put all the radiation where they want it and no radiation anywhere else, they're always going to choose that treatment. That is the best treatment. And so, deep down in all of us, we really want proton therapy to work just as well as radiation with X-rays. Where we get into trouble is that the proton therapy is much more expensive, and a lot of the technological developments that are commonplace with X-ray machines are not in place with the proton therapy. And I think I can demonstrate that a little bit in the next screen, particularly with prostate cancer. Okay, this screen is 3 different views of where the radiation's being deposited in the tissues. So these are CT images. The left column is an axial CT image through the prostate. The middle column is a coronal image of the radiation going in to the prostate on CT. And then on the right hand is the sagittal view. And what I want you to look at here is this is showing where the radiation is going. The blue dose is what's called a low dose of radiation. And then as we move towards the red color, the dose is higher. The areas where you see red and a little bit of the yellow, that's the high doses of radiation. And where you see sort of the green and blue, that's the low doses of radiation. One of the things that's particular about radiation therapy that we have found over the last 50 years, and particularly over the last 20 to 25 years, is that low doses of radiation therapy don't appear to have any side effects. In other words, these low doses are not damaging tissue. Now, we know from other studies that have been performed that these low doses can put you at risk of developing a cancer as a result of that exposure to that radiation. But it turns out that risk is a very low risk. In other words, it's a risk that's on the order of like 1 in 100,000 or 1 in 500,000. It's very rare that I think I've ever seen a prostate cancer patient who got radiation develop a cancer as a result of that radiation. But this is a very big concern in children, because children are living for a longer period of time. If we use radiation on them, we worry that they will develop cancers as a result of that radiation exposure later in life. And when we mean later in life, we're talking 40, 50 years later. With men with prostate cancer, as they are usually older, typically in their 60s, sometimes in the 50s, rarely in the 40s or in their 70s, they're just not going to live long enough to develop radiation-induced malignancy from these low doses. So looking up at the top, the standard X-ray radiation that's given is given with multiple angles. In fact, these days you're treated usually with what are called dynamic arcs, which means the radiation centers on the prostate, and then the beam moves around you in a great circle, sort of kind of the way your belt moves around you. And it gives off radiation as it goes. This is the real benefit. It's basically where all those X-ray beams cross that the dose is really high. You can kind of think of this as the backwards of an incandescent light bulb. So a light bulb shines outward in all directions. Here we're giving the radiation inwards from all directions. And you can see how that bathes you in that low dose of radiation. And so you see that blue kind of everywhere, but then it concentrates in the rectum. And because we can change the aperture of the beam and the intensity of it, we can literally bend it around the rectum, which is where you see how it's kind of bent a little bit on that axial view. If you look at the second row, which is proton therapy in its most common administration, which is with a beam from the right and a beam from the left, you'll see there's almost no radiation administered in front of or behind the prostate, and really it's all coming in from the sides. But if you look at the red and yellow areas, you will see, if you look at all of the screen, that those are basically the same as with the external beam radiation therapy. The bottom row there is a more fancier form of proton therapy where they're treating you, in this case, with 5 beams, sort of in a hexagonal approach. And you can see there that it's really only a little bit of blue, and all of the red and yellow, again, is exactly the same. Because it's the red that gets rid of the cancer, and because it's the red that causes the toxicity, you can see why most radiation oncologists don't believe there's a big difference between X-rays and photons. And instead, the big difference is cost. Unfortunately, the proton machines are just too expensive, costing multiple millions of dollars, tens of millions of dollars. They say they can build one for like $35 million. I don't think one has been built for $35 million. Most of them are in the neighborhood of $40 to $50 million if you're talking about a single vault, and upwards of $100 million or more for multiple vaults. So as a result, these have not been very economical, and that is the real big debate. If they could sell these things and make them twice as expensive as a regular radiation machine, then you'd see them scattered all across the United States of America and everybody converting to them. One of the other problems is the biggest advantage that we have with modern radiation is that concept of treating from multiple angles from the outside in these continuous arcs. You can't really do that with a proton machine because the gantry, that's the device that changes the angle, moves very slowly, is enormous in size, and the engineering feat it would take to make those move fast would be very difficult. As a result, if we did multiple angle treatments with protons, they take much longer than a regular radiation treatment. Remember, a regular radiation treatment's literally 10 minutes. And these treatments would be on the order of 4 or 5 times that long, maybe even longer. And so because of that, it has been a sort of functionally not tenable. As far as results with proton therapy, the only place that has real long-term results have come from Loma Linda. We're starting to get more long-term results from other institutions that have put prostate cancer radiation with protons on their agenda, but the longest ones come from Loma Linda, and they basically show results that are very similar to external beam radiation therapy. Here is an example of bowel problems from the proton therapy from Loma Linda, and you can see their results at 3 years, which is usually one of the hallmarks for late toxicity. It's hard to get late side effects after 3 years. Is about 7%, which is very typical with most forms of external beam radiation therapy. These days, in fact, we're a lot less than that with the modern arc-based treatments and with some other new developments, which I'll talk about later. Of interest, there is now a big randomized multi-institutional study comparing protons to photons. It's accruing patients now. There may be more than one. The one that I'm aware of is something called the COMPARE study, and they have started to accrue patients. They aren't quite at 25%, and I'm not sure how they're accruing patients because in some arms they have more accrual than in other arms. For some reason, their pragmatic proton arm, which I think is a hypofractionated arm, has accrued almost its total number of patients. whereas their photon arm is only about halfway to a quarter the number of patients that they want to get on that study. But we will wait for the results of that study to see if it makes a big difference or not. Okay, moving on. Now we're to the ones that are much less standard of care. The first one of these I'm going to touch on is cryotherapy. This is where you freeze the prostate gland. The most common way to do this is to put a bunch of small catheters, very similar to the prostate brachytherapy, into the prostate, and then they basically circulate liquid nitrogen through those catheters, and it literally freezes the gland. It turns out that freezing kills the gland. In this case, you have to use something called a urethral warming catheter. Otherwise, you kill the urethra. And this appears to be the biggest problem with many of these thermal type treatments. With cryotherapy, if you really, really freeze the gland, then the gland dies and you get a host of urinary problems from that. And it's because too much of the gland is dying too quickly. And so because of that, that's probably the big problem with the cryotherapy. There has been one randomized study comparing external beam radiation therapy to cryotherapy. The radiation therapy on that study was not as good as it is today, but nevertheless, when you compared the two, the biochemical-free survival, that means the likelihood that the patient's PSA will stay down and not come up, was inferior with the cryotherapy. As a result, doing cryotherapy to the whole gland as definitive treatment for prostate cancer is pretty much out of vogue and is not used very much anymore. I will talk a little bit later about new ways of repurposing the cryotherapy, but we will move on to the next one of these treatments. Here's just some survival data from a study looking at cryotherapy as salvage treatment. So if you undergo radiation and it doesn't get rid of the prostate cancer in the gland, one option is to undergo cryotherapy, and some of those studies have been pretty beneficial. If you look over there at the metastasis-free survival, it looks like it's at about 75% long-term. That's comparable to salvage prostatectomy or salvage radiation treatments. So cryotherapy may be a good choice for treatment after radiation if the cancer comes back in the gland. Okay, the next one of these is high-intensity focused ultrasound. The most common way of administering this is they put an ultrasound catheter into the rectum. This ultrasound catheter allows you to visualize the prostate and the rectum and the bladder, and then you can plan how you're going to administer the high-intensity focused ultrasound. Then they focus those ultrasound waves at a specific point in space, and that heats up the tissue. In this case, we're not freezing, we're basically cooking. And this basically burns the prostate gland and gets rid of it. Again, the big problem with this is as you kill the prostate and you kill it too quickly, this causes a lot of swelling and pain, and then you can get obstructive symptoms. Basically, the prostate swells up so much it can't pee, and it's not uncommon to have to get a TURP or a transurethral resection of the prostate. This is kind of the Roto-Rooter job where they insert a device into the urethra and open up the urethra by taking away some of the tissue in the prostate area. They do that ahead of this treatment sometimes or after the treatment to prevent urinary obstruction. This has never been compared directly with any of the other modalities to my knowledge. So it hasn't been compared to radiation and it hasn't been compared to surgery. So we don't have any direct randomized comparison studies. There are some studies that show some okay results when you do the HIFU, high intensity focused ultrasound, to the whole gland, but there are not any big comparison studies. This has largely been abandoned because of the toxicities, and then when you stop giving the high-intensity focused ultrasound to the whole gland and start to spare tissues in order to prevent it, then the control rates go down. As a result, I don't think you can get this in the United States anymore. I think they do not have FDA approval for treatment of primary prostate cancer. There are some studies looking at it, using it in a different repurposed frame, which we'll talk about a little bit later, but this is not a good treatment as definitive treatment for the whole gland. It can be used, again, as salvage after a radiation failure, and there are studies that show some okay results with that, but again, I think you have to be careful. And there are more studies with cryotherapy, salvage prostatectomy, or salvage radiation therapy that probably show a little bit better data, and there's more of them, which makes them a little more reliable. Okay, the last one I'm going to talk about is laser ablation. This is, again, thermal treatment of the prostate. This is very similar to the high-intensity focused ultrasound. However, in this case, they're using a brachytherapy type approach where they put a needle through the perineum again. And so far, this has never been used to treat the whole gland. Instead, they're using this to treat a portion where they see prostate cancer. And I'll talk a little bit more about this when I talk about the repurposing of some of these localized treatments, where they stick the needle in and they basically thermally ablate with a laser the cancer within the prostate. So far, this appears to be good. I'm sorry, I've got the HIFU data still stuck on there for this screen, but this is all very experimental at this point in the game. I'm going to move on to how they're repurposing these treatments. So all of these thermal treatments, these thermally ablative treatments, either freezing or cooking with laser, HIFU, cryotherapy, radiofrequency ablation, there's a bunch of them out there. The big problem with this is if you treat the whole gland, it's basically too much, too fast. And then you have all this dead tissue, which gets all inflamed, and then you have to get the patient through this period of time where all this necrotic tissue is causing all this damage and scar tissue, and they end up with late complications. So the solution then is really, let's not treat the whole gland. If we don't treat the whole gland, then you won't have this big problem. There's a big problem with that approach, which I'll discuss briefly at the end of this, but there are multiple studies being conducted that are looking at this approach. This is a list from clinicaltrials.gov, and as all I typed in was laser ablation prostate cancer, and you will see there are multiple of these focal laser interstitial thermal ablations of patients with prostate cancer. You can see it's being done at the Mayo Clinic, it's being done at Emory, UCLA, it's being done in Canada at Princess Margaret, University of Chicago, as well as in Italy and Amsterdam. So these are all studies that have been done or are actively recruiting patients, and they're awaiting results. The idea behind this study is sort of a watchful waiting plus or an active surveillance plus. If you're a patient that's a candidate for active surveillance and you want to continue the active surveillance without having to undergo radiation treatment or a prostatectomy, maybe we can treat the focal area that we see the prostate cancer on MRI, and that will allow you to continue on the active surveillance for a longer period of time, and then you may not need a more definitive treatment like prostatectomy or external beam radiation therapy or another form of radiation treatment. How much this affects you and whether you get into a situation where if you've had multiple of these laser ablations and you have to undergo a prostatectomy or have to undergo external beam radiation therapy, does that mean you're going to have worse results from that treatment? Those are the things that we don't know yet because we're early in this sort of novel approach. The biggest problem with this approach is we know that it's probably not treating all the prostate cancer in most of the patients. One of the first studies done with MRI was they did MRIs on patients right before they underwent a prostatectomy, and then they compared the prostatectomy specimens to the MRI. This is a picture of this where you see the histological specimens on the bottom row, and then you see the MRI on the top row where they're sort of outlining the cancer on the MRI, and then they're showing you what the cancer looks like on the prostatectomy specimen. And in this case, you can see that they're very similar, but you can also see the shapes are a little bit different. And that's because even though MRI is very good, like where it says, hey, there's prostate cancer here, there's usually prostate cancer there. But where it says there's not prostate cancer, it's not uncommon for there to be prostate cancer at that location. Now, MRI has improved, and we have other imaging modalities that have improved, so maybe we can start to take these approaches where we're not treating the whole gland as we move forward. So in other words, what are the positive predictive value, which is basically if we say there's prostate cancer there, how often is it there? And what's the negative predictive value when we say there's not prostate cancer there, how often is it not there? These are the data of that, the PPV and the NPV for MRI. And you can see that the NPV is getting better. It's in the 80s and 90s, as you can see on the screen. Historically, it has not been that good. It's been in like the 30s. So as we start to combine these imaging modalities, maybe we really can select patients for partial prostate treatments. But all of this is experimental. It's exciting, it's stimulating, but it's experimental. I would encourage you to participate in studies like this because it's going to help us to understand it. But we don't know what the outcomes are yet. So it's not as dependable as sort of surgery and radiation, which basically represent the gold standard. These treatments may be really good for salvage after radiation therapy, which I think is a great place to be developing these kinds of treatments. But as primary treatment, I'm not sure that they're ever going to make it. Now, the watchful waiting plus approach, there might be something to that, to allow people to continue on watchful waiting for longer periods of time or just avoid the need of definitive treatment for prostate cancer. But I think it's going to take a while before we got that data to prove that you can get away with that kind of an approach. Okay, now I'm going to kind of go into the comparison aspects of these, and these are sort of relatively new developments. The first one of these I'm going to go through is something called the PROTECT trial. This is a very important trial from England where they took predominantly low-risk prostate cancer patients with some intermediate risk or early intermediate risk prostate cancer patients, and they randomized them 3 ways. Basically, they flipped a weird 3-sided coin, and if it came up heads, you got surgery. If it came up left tail, you got radiation, and if it came up right tail, you got active monitoring, watchful waiting, active surveillance, however you want to look at it. The way they did their active surveillance on this study, which is important, and a lot of people are going to complain about how they did their active surveillance. In this case, it was very simple. If your PSA doubling time was a year or less, then they recommended that you get treatment. So in other words, if your PSA goes from 4 to 8 and it does it in a year or less, then you had to get treatment. If you look at these curves at the bottom of the screen here, the curve on the left shows the patients who were randomized, how many of them underwent the treatment they were supposed to go. As you can see, most of them that were assigned to radiation got radiation. Most of them that were assigned to surgery got surgery. And then on the active monitoring group, what you'll see is that by the end of 10 years, those are years on the bottom of the graph, you'll see that half of them ended up getting definitive treatment, probably because they met that rule of their PSA doubling in a year or less. If you look on this study, the prostate cancer specific survival, this means the number of people who died of prostate cancer, or actually the inverse of that, the number of people who didn't die of prostate cancer. You will see that nearly all of them are alive 10 years later, regardless of which treatment approach they took, whether they got active monitoring, radiation therapy, or a prostatectomy. Very few of them died from prostate cancer. This was 1,500 patients on this study, and I think 6 of them died within 10 years of prostate cancer. So it's very rare to die of prostate cancer, no matter how we treat you, within the first 10 years. If you look at the next curve over, that's the curve on the far right, you'll see freedom from disease progression. What this was defined as on this study was the development of metastatic disease, either cancer in the bone or cancer in the lymph nodes. And what you will see there is the blue and the red, which is the radiotherapy and the surgery groups. Very few people developed disease progression. At the end of 10 years, I think it was 2 or 3%. However, in the active monitoring, it was actually about 10% higher. So it was more like 12 or 13%. So if you look over here, you'll see that difference. What that means is that in another 5 to 10 years, many of those patients will die of their prostate cancer, and so you will see that prostate cancer survival curve start to split away in the active monitoring group. So what this does show you is that your lifespan, if it's 10 years and you've got a low or early intermediate risk prostate cancer, then it doesn't really matter how you're treated. That's what this study shows. It also starts to hint that it does matter once you get on beyond 10 years. We will be awaiting the 5-year results of this study, which should be coming out next year, and to see whether or not that is true, but most of us expect to see that. This is probably the next most important part about this study is they looked at the side effects. And this is where I'm going to talk a little bit more about side effects. As you'll remember with prostatectomy, the big side effect is urinary problems, mostly urinary incontinence. With radiation, one of the problems with side effects is while you're going through the treatment, we can give you some sort of outlet problems. Basically, you get increased frequency, you get urgency, you have to go to the bathroom frequently, you have to get up and go at night, your stream is a little bit narrowed. We use a lot of Flomax for that. Those are problems that you don't get with surgery. In fact, many times patients that have undergone surgery remark that their urination is as good as it was when they were like 10 years old. They've got a big fat stream. It comes out really good. It's not slow anymore. And all of those we can see on these graphs as we start to compare them. The other problem with radiation is we can cause problems with diarrhea when you're going through the treatment, and then later on there's a risk of getting rectal bleeding. Sometimes that rectal bleeding can be an ongoing problem that you have to deal with for many, many years, and sometimes for the rest of your life, although that's very rare. And then, of course, the thing everybody's most interested in is erectile function, because that's the thing that's most easily affected by any treatment for prostate cancer. And so we can compare the different approaches on that as well. So if we look at these graphs at the bottom of the screen, on the far left is the number of pads per day. So if you have to have a pad in your underwear because you're worried about having some urinary incontinence, then that's higher up on the curve. And what you'll see here is the red is surgery, the orange or yellow orange is radiotherapy, and the blue is active monitoring. And as you can see, with regard to urinary incontinence, you can see that it's a common problem in patients that have undergone prostatectomy. It does improve a little bit with time. As you can see, it peaks there at about 6 months after, where about 40 or 45% of patients were using a pad. And then it drops down below that, getting towards 20 and closer to 15% by the time we're 6 years out. The active monitoring and the radical radiotherapy, you can see there isn't that much urinary incontinence. You see on the active monitoring that it starts to tick up with time as you go further along, and that's probably because some of those patients, remember, are undergoing surgery as their PSA doubling time indicates that they need treatment. The next one moving over is nocturia. That's having to get up and go at night. Again, remember, that is a problem with radiation, but you can see it's kind of a transient problem. So you can see that it goes up in that 6-month period of time, all the way up to, almost 2/3 of patients, and then it starts to go down. You can also see that the patients who have undergone surgery are better than both the active monitoring and the radiation group, and that's because they removed the clogged coffee filter, and so people can sleep through the night. And so that's actually one of the benefits of surgery that is not usually talked about. And then if you go over to the bowel bother score, you can see there's no difference between prostatectomy and active monitoring, but you can see that there is some bowel bother with the radiotherapy. One of the complaints that radiation oncologists have about this study is that their radiation that they administered on this study, which is from England, and it's like 15 years old, is not top of the line radiation, and so much of that is probably not there anymore. But you can see that difference with regard to that. And then when we look at erectile function, you're going to see, patients with more problems with erectile function. On the top is surgery. Now, the surgeons are going to complain about this study as well, saying the English people don't know how to do surgery, or saying they didn't control for the surgeon, they didn't do all the great surgeons, and there is a point to that. Surgery is a craft, it's an art. There are people who are going to do it better than others. The interesting part is if you look at the radical radiotherapy, they're worse than the active monitoring initially. They improve a little bit, but then you'll see the active monitoring actually starts to get worse to the point where 6 years later, you're a little better off if you got radiation than if you got active monitoring. Those are probably not statistically different at that end of the curve. And again, that's probably because many of the people on that active monitoring group ended up getting surgery for their definitive treatment when their PSA doubling time went up. By the way, you can find both of these studies. They're available. I recommend you look at them. They're from the New England Journal of Medicine at the end of 2016. If you just type in PROTECT trial under Google, you can find them. At the bottom there, you can see the references. All right, moving on. So, because one of the biggest problems with radiation therapy is radiation to the rectum, it turns out we've come up with a new device to help us with that. That device is called the Space OAR. I'm going to try and move a little bit faster now because we're running out of time a bit. But what we do in this case is we literally just push the rectum and the prostate away from each other. And the way we do this is we insert a needle into that space between the rectum and the prostate, and we insert this hydrogel. And what this gel does is it basically just sits in there, separating the two. And it sits in there for a period of about 6 months and then dissolves. Getting it in there is no fun. I've put in, like 150 of these over the past 3 years. And what I've found is that it's no fun getting it in there. But once it's in there, patients don't even know it's there. And as you can see over here on the right side of the screen is an MRI. The prostate is at the top of the screen and the rectum's at the bottom of the screen, as you can see with the arrows. And what happens is we just insert that gel. Here you can see it on the left side where the gel is in there separating the rectum from the prostate. And here it is on the MRI separating the rectum from the prostate. And what this allows us to do is radiate the prostate without radiating the rectum as much. They've run a randomized study radiating patients with the Space OAR versus without. And here's what they found. We decreased the late toxicity from the radiation therapy. Now, interestingly enough, we did not decrease it very much, mostly because there wasn't very much to begin with. 98% of people with the spacer in place had no late toxicity, and in the control group it was 93, meaning only 7% versus 2% were affected. That's a 5% difference with grade 0. It's a 3.6% risk with grade 1, which is probably some rectal bleeding that spontaneously resolves. And grade 2 is when you have rectal bleeding that requires intervention. You have to take drugs, enemas, maybe even small surgeries. And that was only 1.4% with modern radiation. Nevertheless, it does reduce it. And that's especially important now that we're shrinking the number of treatments as we're worried about damage to the rectum. Your radiation oncologist may or may not recommend this. You may want to talk to him or her about it. Here's just some pictures of it on CT scan. This is from one of our patients at UNM Cancer Center. In this case, we put a little bit of iodine contrast in with the SpaceOAR device so that we can see it while we're planning the radiation treatment. It turns out they have a new one where it's now bonded to that, so it stays in there with the patient the whole time, which helps us with our daily treatment alignments. Okay, the next interesting development, and this is the use of focal therapies in patients we wouldn't normally use them in. Our imaging tools have gotten better, and as they get better, they open up the opportunity for us to use localized treatments more aggressively because we're identifying small foci of the cancer in other parts of the body, and now we're wondering, would we benefit from treatment to those areas? Historically, we have not benefited from that, but maybe that's because we're not seeing them early enough. And as our systemic therapy gets better and better, maybe it's more important to get rid of those areas where we see the cancer the most so that the systemic therapy can work longer. So in the cases of patients with metastatic disease, the most common treatment is to put people on hormone therapy. And you will hear talks about that. You've either already heard them or you will hear them once I am done. But in the cases where we're starting to see that PSA rise after you've had radiation or surgery, there are now new imaging tests that can be administered. Some of these are not so new, where they're basically PET scans. And we're giving drugs that go to the prostate cancer, and then they give off radiation so we can identify where they are. An example to this is on the left. On the left, you're seeing what's called an Axumin scan or a fluciclovine scan. It turns out your liver takes up quite a bit of it, which is why the liver is lighting up in the upper left-hand portion of the screen. But down at the bottom where the arrow is, you can see a lymph node taking it up. That's a lymph node with prostate cancer in it. So the question is now, what happens if we treat that, either with radiation or surgery? And there's more and more studies coming out suggesting that patients benefit from an aggressive local treatment if you just have a few of these spots. A few typically meaning 5 or less, in some studies 4 or less, in some studies 3 or less. But really, if you just got one of these, maybe we can zap that one spot. And even if it doesn't cure you, it may prolong the time in which the hormone therapy works. Because when prostate cancer patients get into trouble is when they get to the point where the hormone therapy isn't working anymore. So when you've got metastatic disease and they got you on hormone therapy, it's going to work, and it's going to work for a while. How long that while is variable depending upon how aggressive your disease is, but eventually it will quit working. That's when you're in trouble. So really the goal here is to keep it working for as long as possible, hopefully for the rest of your natural life. So on the right here is one of the studies done. This one was done in Europe, and they compared doing radiation to this spot versus giving standard treatment, and it suggested that you were able to go without hormones for a longer period of time, and it suggested that the cancer was less likely to come back for a longer period of time when compared to other studies. There's when compared to standard of care treatment. There is a big complaint about this study that about half of the patients received a temporary course of hormone therapy, which may be responsible for all the results. Another study has been performed. Here's just another one of those studies. This one is the SABRE Comet study, and it was not just for prostate cancer patients. This was also for breast cancer patients, lung cancer patients, and colorectal cancer patients. And they looked at giving standard of care treatment for patients who just had a few spots versus giving standard of care plus radiation to those locations. And what they found on this study is that overall survival was improved, as was progression-free survival. There are some legitimate complaints about this study as well. So this is still a debatable topic, but most oncologists, if you've just got 1 or 2 spots, are probably going to recommend that you consider radiation. And many oncologists would recommend looking for them. Some of it depends upon your exact circumstances, but you will find that this is going to be utilized more and more. The last thing, looking at localized treatments in prostate cancer, is an aspect of the STAMPEDE trial. The STAMPEDE trial is a huge trial being done in Europe looking at multiple aspects of prostate cancer treatment. In this case, what they looked at is patients with metastatic disease and whether they would benefit from radiation to the prostate. Historically, we don't give radiation to the prostate in patients with metastatic disease, so on this study, they decided to do it. More and more data is suggesting that if we get rid of the biggest area of your prostate cancer, maybe then the hormones work longer and you're more likely to be alive. Now, what they found in this trial was there was not a benefit. So if you look on the left-hand side of the screen, you'll see overall survival, and you'll look at the control group versus the radiotherapy group, and those curves are exactly the same. However, if you look at patients who have a low metastatic disease burden, in other words, these are patients who don't have multiple spots of cancer all over the body and instead have a small number of spots. And on this study, I think they were of the 4 or less spots confined to lymph nodes or bone metastasis of the spine or pelvis. In this case, it turns out radiation to the prostate actually helped. So you can see here that the control group is a little bit worse than the radiotherapy group, with the radiotherapy group more likely to be alive, 4, 3, 5 years later. They are now expanding this and they're looking at the role of prostatectomy in this. There are some people who think that it would be even better if we'd actually radiated the metastasis. In this case, we only radiated the prostate and left the 4 or less metastasis alone. They didn't include that in the study. So some people believe that if we look at those, then we can do better. This is also particularly probably going to change how we treat metastatic disease using localized therapy. I think there's actually a study looking at cryotherapy of patients in this particular area where they have a low metastatic disease burden. I think that's all I got, and I'm ready to answer questions as soon as you are.
So welcome back, everybody. I hope we all enjoyed the much needed break. And now it is my honor and privilege to introduce Dr. Barbara McEnany, and she is the founder and CEO of the New Mexico Cancer Center. She is also a past president of the American Medical Association, and Dr. McEnany has spoken at a previous conference and was warmly welcome. And as a personal plug, I am a patient and a participant with her center, and I want to thank her for having a world-class facility in Little Albuquerque. So, and I also ask you to use the button at the bottom of your screens to answer questions. And now, here's Dr. McEnany's presentation.
Good morning. It is my honor to be asked to deliver a talk on rural health care for the Prostate Cancer Support Association. I am Dr. Barbara McEnany. I'm a medical oncologist hematologist and also the CEO of New Mexico Cancer Center. I wanted to let everyone know how important rural health care is, particularly for our state. New Mexico is considered either mostly frontier or rural. Frontier is even more sparsely populated than rural, and that really makes delivering health care difficult. Everyone would love to be able to have health care next door to their house, but it just isn't possible to have the Cleveland Clinic sitting next door to a small village or town in rural America. And 40% of Americans live in rural areas. As you can see from the slide, almost half of our states, the entire middle swath of New Mexico, is considered frontier, which means there are very few physicians and very little population in those areas. The main areas for New Mexico are no surprise to any of us. It is the Albuquerque-Santa Fe corridor, Farmington area, and Las Cruces. That's where the majority of the population is, and it's where the majority of the physicians are. Let's look at primary care. Primary care is really a struggle these days. Most of you are struggling to find a primary care physician. I've discovered that primary care is a revolving door where you get to know someone for a year or two and then they're gone and you have to replace them with someone else. Well, why is this happening? It has multiple factors causing it, but look at where we are here in New Mexico. For primary care physicians, those red areas on the slide show that there are less than 6 primary care doctors per 10,000 population, actually less than 4. And in the yellow areas, not a whole lot better. And the green area, which is Bernalillo County, is doing okay. It's above 8. But is this enough? And really, to look at it, it's not the number of bodies really that are out there delivering primary care. It's whether or not there are enough primary care doctors to give you care when you need it. And really, the number of visits is the metric that is most important. But this shows why you can't find a primary care doctor. Now, there are benchmarks for these things. National organizations have figured out how many primary care doctors it takes to take care of a population. We use 10,000 people, and we look at that benchmark. So if you look at those areas from that previous map, the red areas are the ones that are doing well. They're above the benchmark of 10 primary care physicians for 10,000 people. The benchmark being 8.29. But if you look at the area that's at or above the benchmark, it's really just a handful of counties for us. That big swath of yellow areas, those are people who are going to have a hard time finding a primary care physician. The problem is it's getting worse. That if you look at this chart, you will see that we were making some gains up through about 2016, 2017. And we were starting to accumulate more physicians in New Mexico. But after 2017, 2018 started to decrease, and 2019 dropped even more. So the net change for primary care physicians across our state shows that we've lost 376 physicians in New Mexico, putting us 183 below the benchmark. For OBGYNs, which probably isn't a great concern to this particular audience, we still have lost 26. And it does make a difference because if you want your grandchildren to be born near where you live, you need OBGYNs. The thing that worries me the most probably is general surgeons. Nationwide, we lose about 100 to 200 general surgeons every year. What that means is that more retire or quit practice than graduate from surgical residencies. This means that general surgery is increasingly difficult to find. And my standard joke is that I want to have all the non-essential organs removed before all the surgeons that I know and trust retire from practice. I actually haven't done that, but believe me, sometimes when I read these statistics, I think about it. In New Mexico, in 2019, we only had 156 general surgeons for the entire state. That's very alarming. We lost 24 from the previous year. And then because all of this plus COVID is driving us all crazy, we're going to need a lot more psychiatrists, and we're losing them too. The most we ever had in the state was in 2017, where we had 332 psychiatrists, and now we're down to 296. This is a problem because we are now learning that mental health is not something that's separated from physical health, but mental health is a key part of everything we do. If you are depressed and you're not exercising and you're too depressed to take your medicine or to do those things you want to do, outcomes are far worse. A lot of states are trying to embed psychiatry in with primary care or with other specialties because it is so essential to help patients understand their illness, work with their illnesses, and just be able to find some joy in your life despite your illness. For this reason, New Mexico Oncology is adding a psychiatric social worker who can help us with just counseling cancer patients, because here with COVID, we are finding that so many more people are scared and depressed. There's the fear of the cancer, and then the fear of COVID, and then the fear of the economic situation of the country, and it is more than any of us should have to put up with alone. So we try to help. Now, why is it so hard to count us? These numbers for physicians are always listed as estimates. Well, in some areas, a lot of the physicians have a restricted number of patients that they can see. In my Gallup clinic, the Indian Health Service patients only see are only seen by Indian Health Service physicians. So those physicians are not available to those of us who do not have insurance through the Indian Health Service. Similarly, the VA only sees veterans. So sometimes those numbers inflate our numbers, but they're not available to the general population. We count physicians as units, one physician, one count. Some people are working part-time. This really is an increasing trend right now. There are a lot of physicians who are starting to work part-time, 80% or 50% of what they did before. Remember, I said that most important metric is how many visits can you have in a certain area? How many people can actually be seen by the physician population? And as we look at part-time physicians, they count as a physician, but they don't see the same number of patients. Administrative duties cut in. I'm guilty for this. I'm mostly doing administration now at this point in my career. But there are a lot of physicians who are significantly younger than I am who are also doing more and more administrative tasks. Part of the problem of this is that there are so many more administrative tasks to be done. One of the things that physicians complain bitterly about is that for every hour we get to spend face-to-face with a patient, there are 2 hours of computer work, of paperwork, of addressing quality measures, of doing the billing properly, of answering various administrative questions. I'll tell you a secret, doctors hate that. We went into this field because we actually like to see patients. We actually like that interaction between a patient and a doctor. I remind people frequently that the doctor-patient relationship is a two-way street. We are attached to one another. And having to be attached that much more to my computer is really irritating. Doctors hate it, it contributes to burnout, but most importantly, it removes doctors from the ability to see more patients. The other problem that in counting people is that a lot of the university physicians do clinical research or even bench research, and that means they count as a physician, but they don't add to the volume of patients that can be seen. Now, I give them a pass because we aren't curing everything yet, so we absolutely need doctors who are dedicated to research and advancing the science. But the other factor that to consider is, while it looks like we have lots and lots of physicians here in Albuquerque and in Santa Fe and Farmington and Las Cruces, a lot of people from outer areas travel in. So while the numerator looks pretty good, the denominator inflates every time patients come from other areas in to see us. The other trend that cuts down the number of visits that people do as a physician is that these days physicians really see fewer and fewer patients than they used to. We have statistics that physicians who are employed by a hospital see 60 to 70% of the number of patients from physicians who are self-employed in an independent practice. That means that that physician is just not seeing as many patients, even though there's sometimes more. And one thing that everyone's heard about that I'm actually getting frustrated with is work-life balance. Everyone who comes out of medical school tells me they want work-life balance. Now, I'm old school, clearly a dinosaur, but to me, my work was my life. And taking care of patients meant everything to me. And this is not the philosophy of most people who are newer graduates. And who's to say who they're right? I mean, many of the older physicians I know didn't see their kids grow up, didn't see their grandkids very often, really suffered from having no family life and no hobbies and nothing else outside of medicine. And that's way out of balance, and I agree. But I think it's important to recognize that being a doctor is not a job. It is a calling. It is not just a career, it is a vocation. And part of what we do when we take that oath that says that we will put our patients before ourselves is that we recognize that our day does not end at 5 o'clock and we punch the clock and we go home. You stay until the last sick patient is taken care of. Now, what does this do with New Mexico? The other problem here is economic. Primary care is the best example of a specialty that has been truly devastated by the economics of healthcare. If you go to school for 4 years in college and 4 more years in medical school and 3 more years to do a family practice residency, you've been in school 11 years, longer than your peers who come out, right away and get a job and start earning income. And with that level of training, people come out also with an average of $200,000 or $250,000 of school loans to be paid back, forced at like 7-8% interest. So they are behind the 8 ball the minute they receive that final diploma and walk out the door looking for employment. So if they look for employment, here are the median salaries that are paid across the state. The problem with this is that if a physician who thinks, gee, I went into primary care because I want to have that long-term, lifelong relationship with patients, I want to see my patients and I want to see their kids and maybe even their grandkids and have them all part of my practice, they're going to be earning a lot less. And so what happens now is you can go and be a hospitalist with a family practice degree, earn $250,000 and work 1 week on, 1 week off, 26 weeks a year, work-life balance, remember, and a lot more money for doing hospital work. This worries me a lot because 90% of what we spend in this country, and we spend $3.3 trillion every year, is spent managing chronic disease. Chronic disease like diabetes, heart disease, prostate cancer, other chronic diseases, and that is not well done in a hospital. To really manage chronic disease, you need to have a long-time relationship with a physician and a team of people to help take care of you. Yet economically, we are disadvantaging anyone who wishes to perform that job and shoving them off to be hospitalists. I was astounded as I traveled the world, or the country particularly, as AMA president, and I visited a wonderful hospital, and I saw the new children's wing that they had created. And it was beautiful. It had some guy's name on the wall, and it was gorgeous. And it had fancy, lobbies and everything else. And it spent $100 million. And I said, we really need a $100 million children's hospital? They said, yes, people stay here for a year because we have to teach these kids how to walk when we've amputated their foot from diabetes, or we need to teach them Braille because they are blind from their diabetes. And that is because there are no primary care doctors or pediatricians out in these little farming communities all across that state who are teaching those kids and their families how to manage that diabetes so that they don't have to learn Braille and they don't have to learn how to walk with a prosthesis. We have our priorities definitely backward in this country. Now, I have some old data from oncologists. Since this is the Prostate Cancer Support Association, I do want to focus a little bit on oncologists. And the study that was most recently done is over almost 15 years old now. And it was done by the American Society of Clinical Oncology. It was when I was on that board. And we studied the number of oncologists that were available to take care of cancer patients. And the unit that we used was a visit, 15 minutes between a doctor and a patient in the same exam room. And what we found was that private practice oncologists spend 90% of their time on patient care. Academics spend 51%. This goes back to that counting issue that I talked about. Now, we need academics because we need a group of physicians who are going to train our replacements, train new doctors for the community, do the research that helps us cure more patients. But there's a toll for that, and they cannot see the volume of patients that are seen by someone in a practice like mine where we do clinical trials, but our focus is on taking care of patients day in and day out. And that is something that we have to consider. So we looked at the number of visits per oncologist. And we found that the average number of visits for older male academics was about 63.9, 64 visits a week. Private practice men over 45 were seeing 103. To my chagrin, women over 45 were seeing 55, and private practice were seeing 90. So women were seeing fewer than men. This is a trend nationwide. Women tend to be more represented in taking care of the family, working part-time, moving their career to being less important than their husbands in some instances, and taking care of more family duties. I will point out that actually in my practice this is not the case. The women physicians of New Mexico Oncology at New Mexico Cancer Center are incredibly productive and are really doing a great thing in terms of taking care of patients. But nationwide, it's a trend. And as more and more women go into medicine, we really have to adjust our needs for the workforce, urban and rural, to make up for this phenomenon, that women are going to be the ones who have the babies and stay home and do a little bit more, about an average of 8 to 10 hours a week more of the housework that are done by male physicians with the same age children. The other trend that I think is worth noting on this slide, and this was from 10, 15 years ago, was that the younger physicians were seeing a lot fewer patients per week than older physicians. This is a generational phenomenon. It is that work-life balance thing I was talking about, but there's a significant drop. And as the older physicians, over half of the oncologists in the country are now over 50. And therefore, when our generation retires, the generation coming up are not going to do the same volume of work as was done before. So the findings from this study was that the supply of visits of patient and doctor in a room together discussing their cancer is going to increase about 14%. The workforce is aging, but patients are aging. They're going to need more care. These amazing new drugs that we have can now turn cancer from a death sentence to a chronic disease, but it requires work. It requires physicians and patients working together. And so we estimated that that demand for increased visits would be up by 48%. We have seen that come true. We predicted it in 2006 as 2020, and it's holding true. And the survivorship is a good thing. We just need doctors who are able to create that survivorship. So what we're seeing is a significant shortfall of oncologists, 2,500 to 4,000 by this year. And this includes trying to offload to those poor beleaguered primary care doctors a lot of survivorship follow-up, and to trying to have nurse practitioners and physician's assistants assist us with some of the more routine care. We looked at that as a way to help significantly with this workforce issue. A nurse practitioner or a physician assistant is not trained as an oncologist. When we did oncology training, we did the same 11 years that family medicine did, then another 3 years for a fellowship to be trained in subspecialty oncology. And so with 14 years of training, there's no way a nurse practitioner with a nursing degree, a Bachelor of Nursing in 4 years and 1 to 2 years of training afterwards, is going to ever be able to be a replacement for an oncologist. I know some incredibly good ones. We've got some incredibly good ones in our office who spent the last 20 years with on-the-job training learning how to do this, and they're good. But they don't have the education to set them up to be your primary oncologist. So the way we work with people is, I think, a great way to do it. We alternate visits for people who are on chemotherapy, but the nurse practitioner always has direct access to the physician. Or we have people take the acute visits. If you call up my practice with any version of, I don't feel good today, someone will figure out how sick you are. Do you need an emergency visit? Are you sick we can handle over the phone? Or do you need a telemedicine visit? Or do you need to be seen that day? And our nurse practitioners and PAs do a lot of those same-day visits and then check back with the oncologist. So that relieves the oncologist so that they can go and see more new patients. We projected in ASCO at this study that 1/3 of cancer patients will never have access to a cancer-trained physician, and that is a scary statistic. So when I show this graph and we look at all the various machinations we can do to increase the supply, we fall short. We fall short of cancer doctors to see cancer patients. The other problem we're finding is that burnout is a real thing. And over half of physicians across the country express burnout. And burnout is a problem because if somebody is burnt out, they're not as focused and as empathetic as it is crucial to be, particularly with a cancer patient. They are exhausted. They don't want to be there. And what you really want as a doctor is somebody who really wants to be there, taking care of you, focused on you, not worrying about other extraneous things, or just feeling like they wish they could leave the profession entirely. But we're seeing that about 2% of physicians across the country want to leave the profession. And 1/4 of physicians are considering cutting their hours back or going into another line of work. Another 1/4 are considering retiring early. This is just going to make this worse, and we have to address it. And we really have to worry about whether or not we're going to have enough doctors to take care of the patients that are needed. Even with all the team-based care, even with using physician extenders, nurse practitioners, and PAs to the top of their license to be able to do every task that we can do working together as a team, we don't have enough healthcare workers in this country. Now, I said I was going to talk about surgeons, and I really look at this chart, and I see that there are some areas that supposedly have adequate surgeons, but I will tell you that even here in Albuquerque, it is a struggle to find an oncologic surgeon to operate on one of our patients. It is difficult to find somebody who can do that in a timely manner and with a good degree of competence. And we have some good ones, we have some really good ones, but they are significantly overworked. And so I'm really concerned about this. But talking more generally, I'm particularly concerned about this because of rural New Mexico. In rural New Mexico, if a community does not have any health care available, that community does not have the infrastructure to have an economic life, to be viable. And if there are no surgeons, that local little hospital is not economically viable. Surgeons are the economic engine of small hospitals. Small hospitals make their money in their operating rooms. And if you don't have a surgeon, pretty soon you don't have a hospital, and you don't have the infrastructure of healthcare to keep that community alive. So this, I believe, is a crisis that is not being addressed nationally. So look at this for surgeons compared to the benchmark. The red areas have severe shortages, and there still are very few that are optimal. Green here is considered adequate, but surgeons are also aging. And surgeons, as they age, start to look at their competence and their ability to do that 2 a.m. operation and then work the whole next day. And so they tend to retire a little earlier or to contract their practice a little earlier just out of concerns for patient safety. So the lack of surgeons is a problem. And general surgeons are the springboard for every other subspecialty type of surgeons. So if there are 200 fewer general surgeons being graduated from their surgical residency every year in the United States, then retire, then what is the population of subspecialty trainees? Because they feed from that pool. Some become urologists, some become orthopedists, some become vascular surgeons or neurosurgeons. But if the pool is shrinking, all of these subspecialties are competing for that shrinking pool of graduates. And so how do we find a prostate cancer patient, a urologist, if we are not training enough? And this graph for New Mexico is just terrifying to me. The left side of this, below the line, the decrease, shows the number who've left practice, or they're still in New Mexico and they're not practicing, and some of them have left New Mexico. And some of them have just quit doing their specialty. They're in administration or they're doing something else. And the number of people that are new to the specialty and new to New Mexico is about 30, but we've lost 65. So we have a problem in this state, and it is more of a problem in the rural areas. The rural areas in America are the canary in the mine for everything that is wrong with our healthcare system. So one of the questions is, can we replace physicians, particularly primary care physicians, with clinical nurse practitioners or with physician's assistants? And that was looked at too, because a lot of the time when people are saying, well, let's just grant them independent practice and send them out to rural areas, we found that two things happen. One is they don't go out to rural areas any more than other physicians do. They tend to congregate, as this graph shows, in the urban areas where everyone else is. So that's not a solution really for rural healthcare. Although there are some dedicated physicians, some dedicated nurse practitioners who are slogging it out in rural healthcare without the help that they need and doing an incredible job. But if you look at the bigger picture, if you look at the numbers that we have to look at, They tend to congregate in the same areas as everywhere else. The second part of this is they simply do not have the same education as a physician. We see consultations where someone's been treated for a sore throat for months with antibiotics and nobody saw the tonsillar cancer, or somebody who had difficulty urinating and it took a long time to find that prostate cancer. The education matters. And so I think it's important to recognize that there's an incredibly valuable contribution from nurse practitioners and from physician's assistants, but it has to be in team-based care. And I kind of laugh when people come up to me and say, well, I practice independently, because my answer is I certainly don't. I have my box in which I am competent, and if you are not in my box, I yell for help. If you walk into my cancer practice and you're clutching your chest and having chest pain and shortness of breath, I am not going to say, I am a physician, I'm independent, I'll treat your heart attack. I'm calling for help then and there, and that's the way all of us should practice. So I don't believe in independent practice. None of us are independent. So if we were going to take all of New Mexico and bring us into compliance with the national benchmarks and have enough, how many people would we have to recruit? 336 primary cares, 59 OBGYNs, 11 general surgeons. I don't think that's nearly enough, because a lot of general surgeons just do breast or just do very abdominal surgeries. They are not interchangeable pegs that you can pull one out of a pegboard and put another one in. We need a lot more than that. 106 psychiatrists and almost 6,000 nurses and clinical nurse specialists. So why can't we recruit these doctors? You know, the medical schools are churning them out, the residencies are out there, not in big enough numbers, but they're there. And what are our barriers here for New Mexico? Well, first of all, we pay a lot less than they do in other states. If you move to Texas, you can expect to make $100,000 more per year as a physician. So why would you stay in New Mexico? If you stay here, you're working your tail off. You don't have any time to enjoy the beauty of our great state anyway. You're better off to make an extra $100K living in Texas and come here on vacation. That's not what we need. We need to get parity with this. Medicaid pays 95% of Medicare, and Medicare in my practice pays about 80% of our true costs of delivering the care. The costs of paying a nurse, paying a physician, paying the light bill, paying the overhead, paying to heat it or cool it, having it clean. All of those costs are there every day, and Medicare pays 80%. Yet we have a significant Medicaid population, which pays 95% of Medicare. So 46% of New Mexico is on Medicaid. That means that that decreasing sliver of commercial insurance has to fill in that hole so that I can pay for the costs of taking care of a Medicaid patient. That, when people from out of state look at our state as whether they want to come here and they see the quantity of our people who are on Medicaid, who are on a plan that you cost shift to instead of cost shift from, they think, what are you, crazy? Why would I come here and do this when so many other people are vying for my job? We also are one of 2 states that puts a gross receipts tax on medical goods and services. Hawaii is the other one. Their gross receipts tax is about half of 1%, and ours is about 7%, varying on where you live. That means that if you move across the border to Texas and your gross receipts tax go away, you just got a 7% raise without even changing your practice. That's a problem for us, because remember, healthcare is the infrastructure for other economic development. The other problem I find with recruiting to rural areas is the community resources are not there. Most people these days live in two occupation families, 2 people with a career. If I put a physician in my Gallup practice, their spouse needs to be able to find work as well, and that is really hard in rural areas. The other thing the spouse looks at is how good are the schools going to be? And New Mexico schools are not as good as schools in other states. It's simply a fact. We need to spend more money on teachers and on making sure our schools are performing well, because physicians and physician families care a lot about education. And we want to make sure that the children of our families have a good start in life. I think that should be a universal concern for everyone, but it's a concern for us as well. The other problem we have in New Mexico is a self-inflicted wound. It takes 6 months from when I recruit a new physician to join my practice to when they're fully credentialed with Medicare and Medicaid and all the health plans, and I can actually have them see patients and get paid for that. 6 months. This is a big problem. In this day of electronic information, we ought to be able to fix that problem. We ought to be able to just make that problem go away. And the other thing we have to think about are student loans. If a kid comes out of school, I'm old enough I can say if a kid comes out of school in their residency with $250,000 in debt, what is the likelihood that they are going to say, well, I really want to practice medicine in rural New Mexico, spend 6 months getting credentialed, another 6 months building a practice, loan payments are due, it's economically not viable. We have to address that as well. Let me talk a bit about hospitals. Rural hospitals in this country provide care to 60 million people. And without a hospital in a community, that community struggles to survive. So there have been several important laws that were passed federally. There's the Federal Office of Rural Health Policy, and they created a thing called a critical access hospital and started to pay those hospitals more. The Affordable Care Act requires a group called MedPAC, which is a professional advisory committee to Medicare, to study the adequacy. But look at these numbers for closures. Since 2005, 170 small hospitals in rural America has closed. If you're for-profit, you're more likely to close. Not because you're run less well, but because the tax burden is significant. Southern hospitals were more affected than northern because the southern tier of states did not expand Medicare. So here's the rural healthcare facilities sprinkled across New Mexico. Many of them are what we call critical access hospital, which is defined as having fewer than 25 acute care beds, 35 miles from the next available hospital, and if you have that designation, Medicare pays a little over your reasonable costs, 101%. For any of you who have spent your careers running a business, 1% is not a viable margin. And if you look at this top graph, this is the median profit margins for rural hospitals. And you can see that a lot of them are dropping. They're headed downward, critical access or non-critical access, which just live on the same fee-for-service as everyone else. So this is a very alarming process. If the hospitals, which are often also the largest employer in a small town, if the hospitals can't make it, the physicians don't have a work site, they don't have a place where they can get imaging or do that surgery or get lab work done, then the physicians will leave. And then you have no infrastructure for economic development in small rural communities. So here in New Mexico, we had 10 critical access hospitals. We have some rural health clinics. We have some federally qualified health centers, which are tax-supported institutions that are paid well over Medicaid rates for their uninsured and Medicaid patients in hopes of keeping them alive. And we have 21 short-term hospitals. Now, what's happening with this? I mean, Medicare wants to help, but sometimes the government can't get out of its own way. So it created this process. First, it created a process where we're going to measure quality. And if you're not good and you don't have good quality on these metrics we set up, well, guess what? We're going to cut how much money you have. So look at, for example, my friends in the Gallup area, where they're taking care of patients with a hemoglobin A1C of 13 or 14 when they come in. That's diabetes way out of control. They get them down to 9. They are doing an incredible job. But the benchmark is you have to be under 7 or you get dinged. So if you happen to take care of a bunch of Sandia National Lab PhDs who are weighing everything they eat and measuring their glucose 20 times a day, their control is going to be a lot better than my friends who are working on the Navajo Nation. But guess who gets their fees cut? It's the little hospitals out on the Navajo Nation. It's the little hospitals across rural New Mexico who we cut because they weren't hitting those quality metrics. Well, now we're going to make it even worse. They just proposed a thing they call CHART, which stands for Community Health Access and Rural Transformation. And what they're going to do is they're going to capitate the payment, which means they take all the money they were going to pay you, cut it by 4%, and give it to you in a bundle. The problem with that is cutting it 4%. And it's capitated. And if you don't continue to improve, then they cut it every year. So it takes money to transform healthcare. It takes money to provide the extra services that help people get better and healthier. It takes money to do this. So what do we do to our hospitals that are struggling? We whack them and cut it again. And this graph just shows if they start out with a fee-for-service payment and every year they get this capitated amount that drops down, they're going to end up going under. Any hospital that's looking at participating in this CHART program that's been proposed by the administration needs to think twice. And any community hospital board who's thinking about participating in this really needs to get involved soon. And this was all before COVID. Elective admissions are way down. Even in cancer, we're discovering that the rates of mammography and other cancer screening dropped by over 50%. People just stayed home. People didn't go and get their colonoscopy. They didn't figure out why they have blood in their urine. They figured they'd just cope with getting up 10 times a night to pass urine. They just stayed home while the cancers are growing. And the patients who came into the hospital had an acute need for expensive hospitalization. So this has really damaged hospitals all across the country. They're not seeing those elective procedures that pay the bills. They're seeing 30, 40-day ICU stays with COVID. And that is not a recipe for success. So they've tried to help all of us who are in this situation. The Coronavirus Aid, Relief, and Economic Security Act, the CARES Act, gave some funds. Here, H. Bill 6 fortunately exempted those funds from paying gross receipts tax because they were to make up for the revenue that is lost so that practices and hospitals could stay in business and still be there when and if this pandemic ever ends. They also helped us with telehealth and relaxed those regulations. They made it from something worthless to something else that's more useful. Another issue is the medical malpractice. If I see patients in the office and one of them gets COVID, do I know whether they caught it in the office or they caught it in the hospital or they caught it at home? Are they going to sue me for this? Doctors are a little worried about that. So practices were affected as well. This is data from COVID, from the Community Oncology Alliance. And also it was data that we pulled through New Mexico Medical Society. In New Mexico, 47% of practices either reduced their hours or closed. 41% furloughed staff. Some of the hospitals furloughed physicians, which is astounding to me. Many hospitals across the country, and 38% here in New Mexico, cut people's salaries. It's like, You go to work and risk your life every day, and by the way, we're cutting your pay. 17% of these practices just closed, gave up the ghost. Why is that? Well, they couldn't get PPE, protective equipment. They had more expenses. We're paying people to stand in our front lobby and screen you to see if you have had COVID and take your temperature and make sure you have a mask. The cleaning expenses have gotten significant, and telemedicine. I will tell you, New Mexico Oncology has really weathered this well and worked very hard to make sure that we stayed open. Let me talk a bit first about telemedicine. It took us in an independent practice about 4 days to set up telemedicine. It's very convenient, but I can't examine you. And when you show me your rash, I can't even really see that all that well through the telemedicine thing. But it could potentially leverage the number of specialists without making people or doctors travel. It's way less personal. And I also worry that it allows people to avoid some needed interventions. I wrote unneeded, but that too. That we might be able to save some money because maybe if people don't need to come in, we can do it less expensively. I do worry about cross the state lines, some doctor you've never seen or someone who claims to be a doctor prescribing you chemotherapy, opioids, whatever you might want. So we have to approach telemedicine carefully. I find it fascinating that there are a lot of pundits out there saying telemedicine is what's going to save healthcare. It's a tool. It's like my stethoscope. It's useful for some things, and it's not at all useful for other things. So it's a tool. Don't take the tool away. We like it. We want to keep it, but it's not going to be this savior for healthcare. So what has gone on with my practice, New Mexico Oncology Hematology Consultants, which we practice at New Mexico Cancer Center? Well, we used to have 5 satellite clinics. We used to have a process where we were doing a lot of rural health care. Silver City and Clovis and Ruidoso all got taken over by the local hospitals, and now they are struggling or non-existent, which is not a good move. We have the Gallup Cancer Center, and at first we tried to hire physicians. And we discovered that that didn't work out so well. People looked at taking a job in a rural area as, retirement, or we hired one person who was an ex-professor who didn't understand the really doctor-patient relationship. He was used to having an entourage of people who would actually come and examine the patient and talk to the patient. He'd walk in and go, "You're fine," and walk out, and this was not what we wanted. So now we travel. The doctors go out, stay 1 to 2 days, come back. We see medical oncology, radiation oncology, and rheumatology patients out in Gallup. We have weathered COVID very well. We put in very aggressive screening and very aggressive hand washing and mask wearing and everything else in the practice. And we've done very well. And we recognize that our employees, sometimes their spouses in that 2-income family have lost their jobs. So we took some of that money and we gave a COVID raise, a COVID assistance raise to our employees so that they would be able to continue to come to work, and have tried to be very supportive of them in these really hard times. The New Mexico Cancer Center Foundation, which is our 501c3 that we set up to help patients with the non-medical expenses of having cancer, has become incredibly overwhelmed with the need for food and shelter and travel. We've given away, by paying patients' bills, over $1.5 million just to help patients be able to not have to get chemotherapy living in their car. And so with COVID, it's really a problem as people are struggling with no incomes to put food on the table or pay their copay. The foundation does not pay medical expenses. It doesn't pay me, it doesn't pay insurance, it doesn't buy drugs. It buys food and shelter and patches the roof. And so that's one of the ways that we've helped to address this COVID pandemic. Our basic philosophy has been that cancer doesn't wait for COVID. And we have felt that it was our duty to our patients to keep treating their cancer and to keep them safe and away from the hospitals, because if a cancer patient gets COVID, they have a much higher chance of dying from it. So we keep them away. If, on the other hand, we want our patients not to be in the hospital, because the hospitals right now need to focus on taking care of COVID, and we consider that our duty to our communities. So what could we do with this pandemic to fix this terrible catastrophe that we're looking at with rural health care? Well, it's time to think about what the role of a rural hospital could be. It probably shouldn't be treating COVID people in the ICU. It doesn't have the resources. But every community needs an emergency department, because people are going to have their babies or their heart attacks or smash their cars into each other at 2 in the morning, and somebody's got to be there to take care of them. We need to think about that. If we pay by taxes for fire departments and police departments to keep us safe, maybe the taxes should just directly support hospital EDs, so that patients who come in for an elective surgery don't have a big surcharge to pay for the emergency department that all of us need to have available. After I saw that big hospital building with that guy's name on the side, I thought, gee, wouldn't it have been great if he had taken that $100 million donation and put 50 little clinics across that rural state and provided them $1 a year rent to a primary care doctor and said, you go there and take care of people. That would change the economics of primary care. And he could have his name on 50 buildings instead of 1. I thought it was a great idea. And as I used to say to my dad, I would have had a great career as a philanthropist if only he'd had the foresight to be rich. But since I can't give that money itself, I'm looking for people who can. There are these laws, the Stark laws, that prevent doctors from working together, or doctors and hospitals to pool funds and be able to say, okay, what our community needs is a good CAT scanner or an operating room. We can't collaborate that way because of the Stark laws, which say that if we share resources and refer to the center, we could be banned from healthcare, basically from the Medicare program. Rural hospitals need to have the ability to pool their resources and focus on those essential benefits that are needed for them. We need to pay more for rural health care, not less. It costs me more to deliver care in Gallup than it does in Albuquerque, because I need to pay people more to live in an area where they're going to depend on a one-family income. We need to know what it is that adequate costs should cover. What is the real price of optimal cancer care? Nobody actually knows. They know what they charge, they know what they get paid. If they're positive at the end of the year, they guess that was enough, but we don't know. It's time we know, and that means transparency. We've really got to get out of this system of everybody hiding their costs and their payments, so that we can actually use the health care resources in a valuable way to build a better future for New Mexico and for every other rural state. Thank you very much.
Okay. Thank you, thank you, thank you. Wow. Anything to say, Steve, before I go on?
No, I appreciate all of the presenters and all the work that they put into their presentations. And I'm looking forward to hearing some of their answers, but I noticed that in the questions, there are several overlaps there. So Gene, I'm sure you've probably grouped some of those things together, but
Yeah.
So I'll let you take over.
Okay. So before I go any further, I'd like to welcome back all of our presenters and just everybody, and thank you.
Hello.
Thank you to Dr. Jeswal, Dr. Schroeder, Dr. McEnany. Thank you for being here. And on behalf of the PCS, support group and all of our members and everybody on this call, thank you. I'll just get that, and I'm getting emotional. But As you all can see, we have our presenters here, and if you want, you can answer questions on the bottom there, Q&A. But based on everybody and all the questions, I have specific questions for everybody, but then I also have general. So I'll mix and match them all. And the first question goes to Dr. McEnany, and I'll try and clean it up a little bit. But the question is specifically, what is New Mexico and our local government doing to provide economic incentives for our healthcare professionals? And I know there's a lot of talk about free tuition, free healthcare, all that stuff. Is it being done? And how does New Mexico compare with other less populated states such as Montana, Wyoming, Idaho, etc.? And is there a potential state or federal funding source that can be used to provide supplemental salaries for our people in the healthcare industry?
Thank you very much for that question, and it's an important one. Nationally, if a physician wishes to participate in the public health service, they can get some loan forgiveness for working in underserved rural areas, and that's an underutilized program. We have 2 medical schools now in the state. We need to be able to add some tuition support and to get more local people willing to go to medical school, so that 2 things would happen. One is our population of physicians would start to look more like our population of people. And that would be very helpful because people who come from an area tend to stay in that area. We lose a lot of our medical school graduates to other states. In Montana and Washington, Alaska, they do a combined medical school process there because they can't have each state having its own medical school, but they work very hard to create that. We could do more. Dr. Scrace, as the Secretary of DHS, has worked hard to increase what is paid for Medicaid in rural areas, but it still is below the cost of delivering the care, and it still is not enough to change that economics. So one thing we could do would be to pay people more if they live in a rural area. We could do the debt forgiveness. We could support some of the infrastructure for that area. And the other thing that we could do that I think is most important is decide whether we want to continue having gross receipts tax on medical goods and services. We've whittled them away on some things like Medicare and Medicaid, but it's still there on your copay. It's still there on some ERISA plan insurances. And so it's an economic nuisance for the practices to figure out who you got to pay it on, who you don't. But every year we try to go to the legislature and say, can we get rid of this so that we are on a level playing field to compete in the national market for physicians? And there's always an economic reason for the state saying, no, we need that money right now. We do, but we need to invest more in our future.
Thank you. I knew you had an answer for that. And that was a good one. Dr. Schroeder, you're up, dude. Are there any advances in biopsy methods under study, anything less invasive as far as approaches?
That's a good question. I'm not aware of anything other than the traditional transrectal ultrasound guided biopsy. They can target the biopsy. They have MR fusion techniques, and they have enhanced ultrasound techniques to do a better job of biopsying the areas that are most likely to be involved with cancer. But actually, I think this question may be better answered by Dr. Gesualdo. I don't know, is he on?
Yes,
yeah,
he's there.
I'm here. Yeah, we've been using more and more of the MRI to kind of follow prostate cancer, and people that even for screening, people had multiple biopsies before, and whether or not they should do another one. So yeah, and the MRI fusion, I mean, it's just so unavailable. It's not available here in New Mexico, and I think the closest places is probably Scottsdale and Denver. which kind of makes it very prohibitive for anybody really wanting to get, an MRI fusion biopsy to like leave the state and where to go and be referred to.
This is Barbara. I'm going to mention something on that. We are in the process right now of installing a brand new MRI, which will have prostate fusion possibilities so that we can provide these services locally. We can't do it today because the machine is still in large quantities of pieces in the floor of the suite that it will live in, but it will get there.
That's good. Yeah, I think, like if that was available, I mean, it's good. I think with the, at the national level for reimbursement, from what I understand, there's no financially, I don't know if they give you any more money for doing an MRI fusion biopsy, and you're putting probably an enormous investment into that piece of equipment. So, it's just, I think even at that level, it's even to try to, if to make it more of an incentive for other people to get that, to help pay off for the investment that you make,
Yeah, so good job. Dr. Schroeder, I've got another one for you, sir. What are your thoughts regarding the potential of immunotherapy as a primary treatment or adjunct to surgery? Are there current studies or clinical trials in this area? And if so, what are the preliminary results?
So I'm not aware of any studies that have looked directly into it. I wouldn't be surprised if they're out there, though. There is a immunotherapy agent out there, an immunotherapy treatment for prostate cancer that's actually been around for a number of years, more than a decade. For the most part, it's been utilized in patients that have metastatic hormone refractory disease, and it hasn't really been brought closer in. I think one of the prohibitive reasons for that is the cost of it is rather substantial. Having said that, immunotherapy is a rapidly growing field. Right now, we have a trial at the University of New Mexico where we're using a viral gene therapy agent that kind of induces an immune response against the prostate cancer. It's a phase 3 trial, and we've been enrolling patients on it for the last 6 or 7 years. That looks to be a little bit promising in helping to do that. It's done in conjunction with radiation therapy, with or without hormone therapy, in patients with sort of higher, intermediate, and lower high-risk disease. That same agent has actually been utilized, interestingly enough, in a phase 2 study looking at sort of watchful waiting plus again. So these are patients that are on watchful waiting and they want to kind of do something with their treatment. And so they're giving them that agent without any radiation or without any hormone therapy, and seeing if that results in a more delayed course of active surveillance. Beyond those two things, I'm not aware of anything that's out there. I'd leave it out there for the other participants to see if they know any trials or any availability for anything. But right now, the big benefit of immunotherapy in diseases like melanoma and renal cell carcinoma, non-small cell lung cancer, and others hasn't really translated as much into prostate cancer.
Okay. Anybody else have anything in relation to that specific question?
One of the things that we're really looking at, working at with a consortium of oncology practices across the country with, is radiopharmaceuticals, which prostate cancer is a really good target for that because it makes PSA and nothing does. And then you can hook something radioactive to the PSA attracting molecules. And so we've participated in a couple of clinical trials now with radiopharmaceuticals as a way to sort of deliver radioactive material directly to the cancer cells. And so I think there's a lot of promise for new radiopharmaceuticals coming forward, and we're trying to gear up to get ready to do that.
Okay, thank you, thank you. Dr. Gesualdo, you're up, sir. You mentioned disease progression on patients with lower grade cancer and also repeated biopsies during this period. Yet last week, in a response to a question, it was stated that during the course of prostate cancer, the Gleason score typically does not change. Is there anything, or please define a disease progression. Is there such a thing?
I'm not sure. I guess what they're asking, I guess, in these repeat biopsies, if the disease progression is seen, or if it's, I think maybe there's two different parts when I kind of do the repeat biopsies, and I'm looking for a confirmation that our original diagnosis was correct. You know, somebody comes in with a Gleason 6, 3+3 disease, and we wind up wanting to watch it. The confirmatory biopsy would kind of make sure that we have a Gleason 6 and we're not dealing with something else. Yes, I mean, that's the thing. We do see disease progression, especially on the higher cancers, the 3+4s, 4+3s. I kind of see that, and even notice it on sometimes when we do the surgical, we get a surgical specimen that, we're dealing with like a Gleason 3+4, and then all of a sudden it comes back as a Gleason 8, so that happens often enough.
Okay, thank you for that. And then I'm going to throw a question out there that people have asked me with my medical degree. Is there anything that I can do through diet or exercise to control or reduce cancer? And I'll throw that out to the panel. Is there anything that the person can do?
Well, I'll grab that one as a medical oncologist and try to help. In general, obesity increases the risks of cancer. So exercise and diet are important to maintain health along those lines. For most cancers, it's still avoid smoking, secondhand or firsthand smoke. That's pretty clear. There's some studies for prostate cancer on vitamin D that having adequate amounts is a good thing. But there is no magic pill. It's not that if you eat, broccoli every day, that doesn't guarantee that you will not have a cancer. Cancer is 1 in 2 men and 1 in 3 women. And so one of the main features we're learning is your parents, and it's really hard to choose the right ones to minimize your risk of having cancer. So basically be vigilant, stay healthy, and eat a balanced diet. There is no magic pill out there that's going to prevent cancer, but exercise, don't get overweight, don't smoke, get checkups.
Yep. So thank you for taking care of the broccoli theories.
I like broccoli, but I don't think it's magical.
Okay. Thank you. Here's another question that I'll throw out to the panel. Why would you proceed with a biopsy based on PSA without first doing an MRI to locate specific suspicious areas? Biopsy is an invasive procedure with a risk of infection, whereas MRIs are non-invasive. The standard 12-shot biopsy is random rather than guided. Please comment on why or why you not would recommend a biopsy.
Well, I can take that if Dr.
Okay.
Gesualdo would like to follow up on me. One of the things that can happen with prostate cancer, and it's not uncommon to happen, when you have an earlier risk disease or a lower risk disease, it's not uncommon for your MRI not to show any prostate cancer, despite the fact that there's prostate cancer present. So that is not an uncommon event. And so as a result, if we just did MRI, frequently we would end up with an MRI that was negative. So we'd be doing a lot of MRIs on patients and the MRIs would come back negative. And I don't think that would necessarily change the decision as to whether you're going to get a biopsy or not. Now, if the MRI is positive, then yes, they can use that to help them guide. But in those cases when we don't see anything, that doesn't necessarily mean that prostate cancer isn't present. And so as a result, we haven't gotten to that point where we can see microscopic amounts of cancer in the prostate. Now, if we had an imaging tool like that, then obviously we would lead with the imaging tool to look for the cancer, as opposed to going, with basically a random sampling of biopsy. I don't know, Dr. Gesualdo, would you agree with that statement?
I totally. I think the only time that I kind of get an MRI before say the initial biopsy. I'm more doing MRIs in between after a person has had a negative biopsy, their PSA keeps on rising. So if somebody initially comes in, it's because of health reasons. I got to take them off of, an anticoagulation, or if, they have a cardiac risk or something that, a complication from the biopsy can be extra harmful, so that's when I'll maybe get a screening MRI to see if it's worth the risk. If it's a real high PSA, maybe in an older person, then I would also kind of, just so I would have some good idea about where I'm going to put these needles, and maybe even limit it down so I don't kind of maybe limit the bleeding and the infection risk.
Okay, thank you. Thank you. I'll throw another one out to the panel. Is the prostate symptom score helpful in knowing if cancer is progressing, or is it mostly from BPH symptoms?
I'll start off with that. I see that often on, often enough, where on the surveillance, people that have had cancer for years and some sort of progression of their symptoms occurs. And often enough, that's where one of the things to kind of start thinking about is the prostate cancer becoming symptomatic. Often, practically how it looks when I, sometimes the prostate growth is very irregular internally. So it would cause like more of the BPH type of symptoms. Yes, so I have seen that.
Okay. So, and this is one for Dr. McEnany. Got it on my phone. They have my phone number. Is the New Mexico Cancer Center an in-network provider to the Presbytery Healthcare Plan, specifically the off-the-shelf commercial plan offered to Bernalillo County employees?
Yes, we are in network with Presbyterian. We try very hard to be Switzerland and be in network for everybody.
No, that is good stuff. I'm running through the questions here because I was getting them left and right.
People were asking, were people leaving the state or just leaving
Yes.
practice? And
Go
I
for
had
it.
that one slide, and I think the answer is a bit of both. That we have lost significant numbers of physicians who will just leave the state when, after they get disillusioned, unfortunately, with New Mexico. We've seen a lot of revolving door lately of people who are just gone. But we have a significant number, about 20 per year, who just say, enough, I like New Mexico, I'm gonna live here, but I'm not gonna practice medicine anymore.
Oh, okay, that's interesting. Here's another one for the panel. Does a neutron radiation therapy exist, or has it ever existed for the treatment of prostate cancer? You're smiling, Dr. McEnany.
Neutrons, I don't think so. Protons, yes. And
Yes.
people are looking at heavy carbon ion type of things in Europe. But, if you have an extra $300 million to buy that machine, you could probably do that. But there haven't been any of those in the US yet, though I hear Harvard is considering one.
Okay, wow.
I can answer
No
that a little
neutrons,
bit more.
protons, yes.
I know.
Yeah, so I can answer that a little bit more. Neutron therapy was actually kind of a thing in the 70s and 80s, particularly at the University of Washington up in Seattle. They treated a lot of patients with salivary gland neoplasms with neutron therapy. I'm not sure if they ever did any treatment of patients with prostate cancer, but they were heavy into it for the salivary gland neoplasms, and they had some good data for it. There's a lot of difficulty in treating with neutrons, and so as a result, I don't think that it ever really came to fruition. But as Dr. McEnany says, yes, there are heavy ion centers available in Europe that are actively treating patients. For a while there, the University of Colorado in Denver was actively pursuing heavier ion therapy. I think they finally decided to go with more generalized proton therapy. So those things are out there. The big hurdle for all of them is really money. They're very, very expensive, and the technology has not evolved to the level of kind of ease that you can get with external beam radiation therapy for prostate cancer.
Okay.
The proton guys can do a pretty good job, and like I said, we'll await for the results of those randomized studies. But I suggest that, you know, for treating for prostate cancer, there's probably not a big benefit there. For other types of cancers, there really could be, and so it needs to be further evaluated.
Okay.
I've been looking into the proton things because a lot of folks in the Netherlands are using proton, particularly for people, depending on the anatomy, whether they would get a lot more bowel or bladder radiation in given patients, and have an interesting process where they can go and estimate how much additional benefit would happen from proton versus standard external beam radiation. And so it'll be interesting to watch that evolve over the next several years.
Okay, thanks. Here's another one for the panel. Should both total and free PSA be measured rather than just the typical total PSA? Would this be more helpful?
I'll start off on that one, and then I'll let Dr. Gesualdo comment, because he probably knows more than I do. Originally, the total versus free PSA was really to try and evaluate your risk of having prostate cancer versus having BPH, so that you're not necessarily doing biopsies on patients that have BPH. There's now a whole bunch more tools that are available to evaluate that. Once you've been treated for prostate cancer, I'm not sure that there's a lot of benefit at looking at those. I haven't seen any studies to show benefit for that. So it's mostly just to sort of select, hey, do you need that initial biopsy, or is your elevated PSA from BPH? I'll let Dr. Gesualdo answer now.
Yeah, I mean, you know, people come in with the freeze. I see a lot of primaries order that test. You know, technically, I don't think I ever did since, you know, I mean, so for all the years, I generally just get a total PSA and that's it. I find it's sometimes confusing, and it's, you know, you're basing it on a ratio that gives you a percentage of risk, you know, and I think it just winds up making it, adding it just to more confusion to the whole, you know, testing part.
Okay, thank you. Here's another one that kind of piggybacks on that, Dr. Gesualdo. What percentage of men diagnosed with prostate cancer fit into the lower grade or active surveillance category?
You know, it depends. I mean, you know, right now I've seen that there's a shift. You know, I mean, it's not, without having any firm numbers or anything, and it's just a general impression. When I'm doing biopsies nowadays, I'm seeing more and more of the intermediate and high grade cancers. I think that because of, you know, when the commission came out and didn't endorse like a PSA test in the screening and the different, there's a lot of disinformation that came out, and, you know, with primaries, and they're not doing the screening of the PSAs. I'm winding up with like PSAs that are higher in the biopsies that come back as higher. So I don't know how to answer that if it was just a, if we, you know, with in a patient population, how many people are walking around with a low grade cancer, and I would just roughly say probably, you know, majority of them. But, you know, I'm seeing a different thing, but, you know, I'm kind of a, you know, in that special group, you know.
Okay, thank you. Thank you.
I can answer a little bit more on that.
Go
I think
for it.
Dr. Gesualdo is very, very much correct. When the NSFPT, or the Preventative Task Force, came out against screening in prostate cancer a number of years ago, and have since backpedaled a little bit. When they came out against it, many primary care physicians started to use discretion about who they would send for a biopsy. So they don't necessarily send everybody for consultation with a urologist for a biopsy if their PSA is above 4. I think many of them quit doing that. And so what happens is there's a little bit of kind of like active surveillance before you even have a diagnosis that goes on. And as a result, all the stuff that they send to Dr. Gesualdo and the stuff that ends up coming to me ends up being a little bit more intermediate and high risk than it used to be, because we're just not identifying those lower risk patients like we did in the 1990s when everybody that had an elevated PSA was sent for a biopsy. So I think that the answer to the question is, yeah, the majority of patients out there do have low risk disease, but we're not identifying them with a biopsy anymore. Instead, they're sort of being managed before they get their biopsy, which I'm not sure is the best thing. I think it would be better if they actually consulted with the urologist about all those risks. But I guess it really depends upon your primary care physician and how smart they are about prostate cancer.
Okay, that's good. Just fumbling through the, you want to say something, Steve? You just popped in.
Well, we're running out of time, and frankly, I think we're starting to lose our audience here. So, does anybody have any last of our panelists have any last thoughts that they wanted to share with anybody?
Well, I just want to say that on behalf of New Mexico Cancer Center, we really appreciate being able to have such a vibrant organization as the Prostate Cancer Association in the state. You guys do a great job. You have put on wonderful meetings over the years, and it's always an honor to participate. So thank you very much for inviting me.
Well, you're certainly welcome.
Thank
We really
you.
appreciate your being with us.
Yeah, I would echo the same thing that Dr. McEnany said. You guys are doing a bang up job. It's great to have you as a resource. I've been referring patients to you that have a lot of questions and a lot of concerns. And it's helpful for the whole state and for all the men in New Mexico that end up with prostate cancer. Thanks for what you do.
Well, thank you very much. We do appreciate that, and we hope that that we are indeed providing a service to you as the medical professionals. We certainly are not medical professionals, but you know, as Dr. McEnany says, you know, how much time can a physician actually spend with a patient, you know, and can they answer all the questions? And probably not. And that's where we try to fill in the gap. So with that, I would just say thank you to the panelists, and you're free to turn off your cameras. We're going to send out a little poll to our to the remaining audience here to answer questions about how we're doing. If you could take just a few minutes to answer these questions, we certainly would appreciate it. I'm going to go ahead and send that out poll now to you.
All right. Thanks, everybody. Bye-bye.
Thank you.
Doctor. Thank you, Dr. Schrader. And while this is going on, we thank you, the audience, for being here. I wanted to say that these presentations are all been recorded, and last week's is up on the website and can be accessed going to our website, clicking on Fall Conference, and then going and looking for the link, the YouTube link to last week's presentation in case you missed it. There were a lot more of, I think that some of our questions that came up today would have been answered, you know, fairly well in last week's presentation. So if you missed last week's, go ahead and look that up. The other thing is that today's presentation will also be up on our website in a few days. Hopefully you'll get it up on Monday. If you know of somebody that could benefit from seeing any part of these presentations, you might direct them to our website, and they can look at either presentation, last week's or today's. I see that we are registering. Some people have answered some of the questions. Let me just roll down here. Well, thank you. I agree that the quality of the presentations was very high. One reason that I just tell you right now that while you're still on here, one reason that we did it this way is because we wanted to make sure that the quality of the presentations was high by pre-recording the actual presentations and then having the doctors come in and answer questions. I think the pre-recorded messages allowed them to be much more precise and concise. as well as having a higher technical quality. And I will be making their presentations available to the doctors if they should so like to use them in other capacities as well. But we do have all of those presentations in their original form on MP4. If for some reason anybody thought that it would be of value to use those MP4s for some other purpose or to share with another audience, please do contact the office and we'll see what we can do about that. Thank you, Jean, for doing
thank
an
you.
excellent job of moderating. Let me see here. I'm just looking at the poll to see how many answers we got. Okay, it looks like almost everybody has had a chance to answer the poll. And if you should think of anything as an audience member, if thinking of anything that would be good for a future conference or a future meeting, as Jean told you this morning, that we do have our Saturday meetings. The first and the third Saturday of every month. We are conducting them right now on GoToMeeting, which is a competitor of Zoom. And if you would like to attend one of those meetings, just contact the office by email, by telephone, or whatever. Contact the office. We will send you a link and you can attend those meetings. They start at 12:30 on the first and the third Saturday of the month. And we oftentimes have a presentation or we will have open sharing if you have some specific questions you want to ask of other members. That is a meeting environment, so it's more interactive. It's not like the webinar where we're just pushing information out to you. It is actually a meeting and you can actually participate live. Anything else?
I just want to plug that, just look us up, Prostate Cancer Support New Mexico, and any ideas or anything you have to make us better, we're all ears. And thank you everybody for participating. I know you have other things to do on a Saturday, but thanks for being on the team.
Well, thank you everybody. And with that, I'm going to end the meeting. I'm going to stop the recording.